Good evening. Good evening, doctors. I am Shailendra Meena from FDC Limited, the makers of Zocon, and I welcome you all in this online symposium with unique theme, Pearls in Dermatology. To tell you more, we have eminent dermatologists from all parts of India who are going to cover 9 important day-to-day topics and will share their practical experience with us. And to moderate the session, we have stalwart Professor Dr. D.G. Saple and one of the leading dermatologists from North India, Professor Dr. Rashmi Sarkar. Before handing over the session to them, I'll give a brief introduction about Professor Dr. D.G. Saple. He is retired professor and HOD of Dermatology Department of Grant Medical College and Sir J.J. Hospitals, Mumbai. He is a fellow of Johns Hopkins University, USA. He has delivered 1,046 lectures at National Forum and more than 100 lectures at International Forum. He was awarded Best Practitioner Award at Dermacon International Congress 2019, and he has collaboration with more than 20 international universities. And currently he is doing research on dermatophytosis on daily dose of fluconazole and its result, and is the first doctor in India to do so. Ma'am and sir, the session is all yours.
Okay, thank you, Shailendra. Thank you, everybody, for joining and this panelist and Rashmi, co-moderator. Now there are a lot of webinars. Every day there are 1 or 2 webinars. There are too many lectures. So people are losing interest. So modify this webinar like 5 days cricket test, then 1 day, and it's like a T20. So we thought of why not to have the pearls of dermatology. So we are 2 moderator, myself and Dr. Rashmi Sarkar. Dr. Rashmi Sarkar, of course, doesn't need any introduction, but I think we have to do the formalities. And she is well known nationally and internationally. She was secretary and president of Delhi State Branch. Then she was joint secretary and secretary at the national level. She's the president of Pigmentary Disorder, and she's the editor-chief in the Pigment Internationals. She has edited 14 books, including Melasma, a monograph, 17 international and 150 national faculty lectures, international positions at many places, Chief International Mentorship Committee, ISD, and so many awards. So I think I have to go about introduction. So I think I'll stop here because we know her. So with this, we can start our scientific session. I'll request first Rashmi to start with our panelist.
So good evening, everyone, and a very warm namaste. Are you able to hear?
Yeah, perfect.
Okay. So good evening, everyone, a very warm namaste, and I'm just very excited today to moderate the session with Saple sir, because who I really look up to. And this is going to be about pearls in dermatology. It's a potpourri of dermatology, leprosy, as well as STDs, and a bit of aesthetics, like an icing on the cake. So you're going to take home some very nice take-home messages. And I'm going to introduce our panelists, and then, of course, we will be hearing them out one after another. Thanks for joining us during this little busy pre-Diwali session. So we have with us Professor Dr. Arijit Kundu sir, and he's an emeritus professor in the Department of Dermatology of KPC Medical College and Hospital, Kolkata. And he's a well-known teacher and a practicing dermatologist since 1975 with 70 publications under his belt. He has several special awards and recognition, including the IITVL Lifetime Achievement Award in 2016 and the IITVL Oration at Dermacon 2015, just to mention a few. He's also been the past treasurer in IITVL and also the chair of various committees, including the Constitution Committee. To me, he's just Kundu sir, and I refer to him for all my, problems that when he's my go-to person for a lot of, dermatology as well as administrative problems. Welcome, sir, on board. Then next is Professor Dr. PBS Prasad, sir, and it's an honor to have you on board, sir. He has completed his MD and DD from CMC Vellore and was a former professor and HOD of DVL at RMMCH. And he's a very, very popular teacher, I must tell you. He held administrative posts like medical superintendent and dean of the Annamalai University and trained 56 postgraduates in a span of 28 years. And he's had more than 100 publications. We all know his publications in leprosy and so many other things which we've been reading since we were students. And he's delivered 5 orations. He's also authored books on leprosy and dermatopathology. At present, he's a consultant at Skincare Clinic at Chidambaram, Tamil Nadu. Welcome, sir, in this program. Next, please. Professor Dr. Taru Garg is actually my colleague, and we share adjacent rooms, in fact. And she is a professor in dermatology and STD in Lady Hardinge Medical College and Associated Hospitals, New Delhi. And she has presented papers in various national and international conferences, has been a reviewer in many journals, and has more than 60 publications and chapters in various dermatology textbooks. And she's also received the Sardari Lal Memorial Award for Best Paper. So welcome on board, Dr. Taru Garg. Next is Professor Dr. Biju Vasudevan. He's also very well known. He's a professor in Armed Forces Medical College, Pune. It's really been great to see Dr. Biju's growth because I have seen him right, in the early days till now. And it's been such a pleasure to watch, his consistency and his gift, in academics. He's a convener, SIG Dermatophytosis, associate editor, IJDVL, has been the joint secretary, IIDVL 2016, and a recipient of the Young Dermatosurgeon and Ellen Sinha Memorial Award, has several publications, that is 94, and he is a quiz master of excellence because he's really conducted many international, national, and so many state quizzes. And we are expecting a lot from you, Biju, in the future as well. Welcome on board. Next, please. Well, Dr. Abhishek Kumar Jha, whom I have really seen, since he was very, very, very young. And he's a director at Needham Skin City and an associate professor at Patna Medical College. He's been the National General Secretary of the Association of Clinical Dermatologists of India, Vice President IITVL Bihar. In fact, he's really been very hardworking, even as the Secretary and Vice President of IITVL Bihar. He's been practicing for the last 15 years, and he's very active in community services, including one of the torchbearers of IITVL Chala Gaon Ki Or program. In fact, the state of Bihar was the first to propagate this. We are really very proud of that, program, because people have taken a leaf out of that book. Welcome, Abhishek, on board. Next, please. Dr. Kanika Sani, and another, dermatologist whom I have seen since she passed her MD. My association is that long, and it's so much of a pleasure when you see them working as consultant. She's an associate professor of dermatology and venereology at AIIMS, New Delhi, and she's been an ex-PGI MD. She's the content editor of IJDVL with 33 publications, 8 book chapters, more than 30 presentations in national conferences. She has got the coveted Kataria Memorial Gold Medal at PGI EMEA Chandigarh, which very few people get, an MGM Medical College Award for Best Paper at 37 Dermacon, amongst so many other things. She has also been an International Society of Dermatology mentorship recipient in Texas, USA, and got many other scholarships. Welcome, Kanika, on board. Next, please. My pleasure to introduce Dr. Uday Sidhu. And she's, of course, heading the United Medical Center and Skin Glow, Bangalore. She's a dermatologist and dermatolaser surgeon, has done her fellowship in Harvard Medical School, Boston. She's also a recipient of the Imric Sarkani Fellowship by EADV in 2013, a pediatric dermatology fellowship in 2014, presented multiple papers, at national and international conferences, and nominated for Skincare Innovation Award at 4th Annual India Leadership Conclave. She's again a person who's just been doing great in academics, and we hope to see more of her in the future. Next, please. Welcome on board, Uday. Next, again, is a person whom I'm delighted to introduce, Dr. Sameepa Samir Mukherjee. Again, somebody I have seen since her postgraduate days, and she is a consultant pediatric dermatologist at Cloud9 Hospitals, Bengaluru, and she's done her fellowship in pediatric dermatology. She has many publications, in 46 publications, 22 book chapters, and many presentations. Recipient of many awards, out of these, the World Congress of Pediatric Dermatology 2017, and recipient of also the Imric Sarkani Non-European Memorial Scholarship from EADV, and as well as the AD scholarship award as well. And her areas of interest mainly are pediatric dermatology, dermatoscopy, amongst others. She's again somebody who has a very keen interest in academics. And welcome on board, Sameepa. Next is, last but not the least, definitely is, we have Dr. Dhanraj D. Chavan, and he's again a consultant dermatologist at Pune, and he's at the Clear Skin Clinics and Hair MD Hair Transplant Center and Vein MD Varicose Vein Center. He's been the winner of the Best Video Presentation Award at the Association of Cutaneous Surgeons of India, and also the Dr. S.L. Wadhwa Award for Best Research Paper from IITVL Maharashtra. We do see him in many invited faculty positions at a very young age. And I think we are going to see him a lot more in the future because he's really done a lot of innovations with special interests of hair transplant, stereotherapy, and autologous fat transfer and liposuction. So welcome on board, Dhanraj. So once again, it's been great having you all on the panel, and we're going to start the discussion. So, sir, with your permission, Saple sir, can we open the discussion?
Please go ahead.
So we start the evening with Dr. Kundu sir. We have introduced him, and I would like to tell you that he is the one who gave this particular nomenclature, TSDF, or topical steroid damaged face, way back in 2006 with Dr. Kaushik Lahiri. He had made up this nomenclature, and he's written a lot on this. So we are keen to hear you, sir.
Just 1 second, please. I'm having a slight problem with sharing the screen. I'll just take a minute.
Elendra, do you have sir's presentation?
Camera off karo.
No, ma'am, he has not shared it.
Okay.
Camera off करना चाहिए तो. चलो. देखो. Sorry for the delay, and I'll just start. Thank you very much, Dr. Rashmi Sarkar, for the introduction you gave me. And now, my topic of discussion today is how I manage TSDF. Am I audible?
Yes, sir.
Yes, sir.
Okay, fine. How I manage TSDF. As far as Dr. Rashmi Sarkar said, Actually, it was Dr. Kaushik Lahori, my student, and myself who described the term TSDF in the year 2006. And we actually, for the uninitiated, it is of course topical steroid damaged or dependent face. And we gave a definition to the term, and the main point here is that it is a damage to the skin precipitated by the irrational, indiscriminate, unsupervised, or prolonged use of topical corticosteroids. As we all know, there are a large number of topical steroids in the market of various potencies, super potent, mid potent, and of low potency, and of course various combinations, some rational and mostly irrational. And these give rise these are abused basically by various people, and there are various reasons for the abuse of the TC. They have enumerated the reasons here. I'm not going into the details because of the lack of time, but mainly you have to consider this that TCs are applied on the advice of friends, neighbors, and relatives, and of course salesmen at chemist counters and on the advice of non-dermatologists, especially quacks. And the conditions where TC abuse occur are enumerated here, and remember they are not only used in diseases where they should not be used. Hello, they should not be used, and also as fairness creams and as moisturizing creams. And this results in dependence as well as damage to the face. Dependence means psychological and physical dependence on the TC due to chronic misuse, and the attempts to stop the offending drug leads to rebound or flare in symptoms. And the damage due to TC misuse can be of various types. There is aggravation of acne. Acne has a side effect which is basically monomorphic. Hypertrichosis, telangiectasia, perioral dermatitis, allergic contact dermatitis, bacterial infection which can be very severe, red face syndrome which is reported by Rappaport et al. In 2006, and which is basically erythema of the face, atrophy which can be very severe, hypopigmentation, and finally tinea incognito. Now, how do I manage this? There are three pillars of management: counseling, withdrawal, and therapy. Now, as far as counseling is concerned, basically, I explained to the patient that topical corticosteroids are actually very good medicines when used at the proper indication, by the proper doctor, at the proper site, and with the proper potency. But whenever it is misused, it can give rise to a large number of complications. And for counseling, I use one of my personal experiences with another thing, that is cigarettes. I used to smoke about 20 cigarettes per day for 23 years, starting from my college life, till in the late 80s I developed some respiratory symptoms. And then I stopped it 30 years back, and since then I've never had smoked a cigarette or had those respiratory symptoms. Mode of withdrawal, there are two schools of thought, gradual and sudden, and I advocate the sudden withdrawal. Again, my cigarette experience is there, because whenever I try to stop with stepping down, that is, decreasing the number of cigarettes, I used to go back to the original. Till one day I had severe symptoms, and then I stopped it completely, and since then I have not smoked. So this sudden withdrawal, however, whatever way you withdraw, gradual or sudden, there is a sequential withdrawal after events after the withdrawal, erythema followed by disconvolution, again erythema followed by disconvolution, sequence of 2 weeks initially, and this 2 weeks keeps on increasing, and finally the patient is off the steroids. But there can be a rebound phenomenon whereas the disease can increase, and that has to be explained to the patient. And due to the withdrawal, you can have various symptoms, particularly the erythema and the dryness and the pruritus and burning sensation. These can be very distressing. The skin becomes very, very sensitive, and we have to remember that. But as far as therapy is concerned, there are two parts of the therapy. One is the treatment of the symptoms of TSDF. Of course, we know all the treatment are there. But as far as the treatment of the symptoms of withdrawal is concerned, we have to remember that the skin is very sensitive, and therefore we have to give ice compressors, brand emollients, and they have to wash the face with a pH balanced face wash so that the skin doesn't get irritated. Acidic procedures have to be avoided, irritating products have to be avoided, and for the itching, antihistamines are given. There are some drugs advocated for the replacement therapy. Onto that, of course, topical calcineurin inhibitors can again cause irritation on the skin. So these are the drugs which can be used, which have been advocated, and this is the method by which we can treat or rather I treat the TSDF. Thank you very much.
Saple sir, you are on mute, sir. Please unmute yourself here.
Dr. Kundu, thank you very much for sharing your experience. It was really nice message.
Hello?
Shailendra, what is the problem?
Hello? Yes.
Yeah.
So,
Shailendra, it is okay?
yeah, thank you so much.
Yes, sir. Okay, sir.
Okay. Dr. Kundu, thank you very much for sharing your experience. It's a very common problem, but it's a very difficult problem. It's very easy to say that you can win over, but your experience is really, it will be useful for, I think, everybody, including me. So we'll go for the next panelist. Our next panelist, Dr. PVS Prasad. Dr.
Excuse me,
Prasad,
sir. Are we
are you
not
ready?
asking questions after this,
Yeah.
actually?
So I'll just give example. About
Okay.
2 months back, one of the patient was landed with the orthopedic surgeon for the
Can you hear?
incurvature of the little finger and the ring finger.
Are you able to hear me?
Yes, yes, ma'am.
Are you able to hear? Actually, sir, I think
Yeah.
we were going to ask questions right after each.
I think no. I'll just. Oh, you want to ask Doctor
Yeah,
right
because
now?
I think
Okay, no
you
problem. No
wanted to
problem.
leave. That was the issue.
Okay, no problem. Yeah.
Yeah. If that is okay, because I think
Yeah,
they were.
no problem, because it should be connected. No?
So, yeah, Kundu sir, we'll just ask you a few questions. Are you there, Kundu sir?
Yes, I am here.
Sir, you've given a very nice presentation. Just had a question for you, one or two questions. One is that can you, use sunscreens, after TSDF, what are your tips on that? Because even sunscreens can be a little irritating sometimes.
Exactly. The sunscreens can be irritating. Am I audible? Am I
Yes, sir.
audible? The sunscreens can be irritating, and therefore we avoid sunscreens if at all. But then again, sun exposure can cause irritation on that sensitive skin. So if at all sunscreens have to be used, then it is better to use physical sunscreens rather than the chemical sunscreens, which can cause further complications. And secondly, even then, I advise my patients not to even use that sunscreen, but use the commonest and the oldest of all sunscreens, that is an umbrella.
Right. So I think that's a very good tip which is there. And the second question was, sir, that what about lasers? Like there is telangiectasia. So, would you really advise, laser therapy in PSDF? And if so, when?
Actually, as I mentioned in my presentation, lasers and other procedures should be avoided during the TSDF. And we have to use the lasers for some of the symptoms of TSDF, such as telangiectasia or hypertrichosis. And for that, I would advise that we wait, because these are things that can wait. We can do it later on. After all the symptoms of TSDF have subsided, after the patient has stopped applying the topical corticosteroids, after that, we can think of lasers.
Right, sir. And you think that psychotherapy is also important in the case of psychological counseling in the case of TSDF?
See, I first attempt counseling, my own counseling. And I would say one thing here, that our MD course, or even later on, is very deficient on how to counsel patients. We have to get. Hello? We
Yes.
have to, everybody has his own method of counseling. Now, there are some stubborn patients who refuse to listen to you, who refuse to stop the topical corticosteroids. In those cases, in extreme cases, I do take the help of a psychiatrist or a counselor. That's all.
Yes. So I think they're very pertinent messages sir has given. And I think, sir, will you be staying with us till the end? Because there are a couple of more questions.
I will, definitely.
Because I think it would be nice because questions are now coming in. So maybe we can put them in there as some.
I will be here, no problem.
Over to you, Saple, sir.
Okay, thank you, Dr. Kundu. It was really a nice one. We'll go for the next panelist. Next panelist is Dr. PVS Prasad. Dr. Prasad, I'll tell you, about 2 months back, one of the patient was referred to me. So he had this incurvature of the little finger and the ring finger. So he was advised to go to orthopedic surgeon. The orthopedic surgeon, after seeing, he said, you go to neurophysician. Went to neurophysician, he did a EMG. You said there is a sensory loss and some motor loss also. Why don't you go to dermatologist? So he was referred to dermatologist. Dermatologist, after seeing, he said there is no evidence of leprosy. Again, you go to orthopedic surgeon. And he went to orthopedic surgeon. That orthopedic surgeon says, if you don't mind, I would like to take an opinion of another dermatologist. The patient landed in my clinic. When he came, I think it was very obvious it was a case of neural leprosy. But neural leprosy is a big problem to diagnosis because everybody's in mind, it has to be evidence based. Clinical findings are also evidence, but some people, the evidence means it has to be for the biopsy or to demonstrate. And that patient, then I told him, look, we can do the biopsy, but biopsy, there was no palpable or thickened nerve. So we did the ultrasound, but did not show any granuloma. So patient said, is there any other way? So I said, we can go for what we call is the empirical treatment. We started, and patient was happy because the symptoms started subsiding. So this is a very big issue in our day-to-day practice. And Dr. Prasad, you have a tremendous experience of managing leprosy. You have author of one book on the leprosy, and you have handled a lot of cases of neural leprosy. So can you share your experience about neural leprosy, including how to suspect, how to diagnose, and how to manage? Please go ahead.
Thank you, sir.
Yeah.
I wish to thank everyone for bringing me on this board. Today, my topic is primary neural leprosy. Next slide. I come from this place. I think most of you would have heard about this, the very famous Lord Nataraja and the temple, a beautiful temple behind the statue you can see. And I hail from this place. I have been here for the past 30 years. Next slide, please. Leprosy is a very interesting topic, especially when you go to the history of leprosy. A lot of money has been spent to know about the history of leprosy, especially. But again, the roots for leprosy, you see that it has come from India and as old as 1300 to 1500 before Christ. Next slide, please. I will not talk much about this person. Next slide, please. Next slide. But I will just spend some time with this great gentleman, Gerard Hendrik Armure Hansen. All of us know that he is the founder of the bacilli, and he first detected the bacilli in the year 1873. And of course, a lot of things happened, but this was considered as a great discovery because this was the first bacterium to be identified in the medical literature. Next slide, please. Now, this discovery was shared by Albert Neisser. Many of us probably may not know that Albert Neisser also had an equal part in the discovery of the Mycobacterium leprae. He only confirmed the bacilli and confirmed, and then, of course, later on, the credit went for both of them, and both Gerard Hendrik Armure Hansen and Albert Neisser. Next slide, please. Now let us go to the primary neural leprosy. Primary neural leprosy has been there in India for a long time, and then in IAL as classified in 1955. But later, the term polyneuratic was changed to pure neuratic, just because the reason polyneuratic means, again, it can be a mononeuratic or it can be a polyneuratic. To overcome that, the differences, and it was reclassified, and the terminology has been changed to pure neuratic leprosy in the year 1982. Pure neuratic leprosy shows no skin lesions, as Professor Sapley told you about his experience, and no skin lesions. That's why it is very difficult to diagnose. But what you can see is large nerve trunks or branches which are enlarged, and the skin smear is negative. You can find a very nice article on pure neuratic leprosy from my friend's article, and that is that which appeared in the Indian Journal of Dermatology, very leprosy, in the year 2016. Next slide, please. There are many synonyms for pure neuratic leprosy, and either now people accept the term pure neural or primary neuratic leprosy or purely neural. So many synonyms are there. Next slide, please. But how do you diagnose? And why do you think it is very important? Do you see those cases now? Yes. There are many articles which showed that near about 4 to 18% of the new cases belong to pure neuritic leprosy. Not only that, the young people are more affected with pure neuritic leprosy. And look at the problem. The median time for diagnosis is nearly about 1.8 years. And there was a delay in diagnosis in about 82% of cases. There was a delay in diagnosis. Another article mentioned that at the time of diagnosis, already the patient had the nerve function impairment. The upper limbs are the most common, where you have the ulnar involvement, or in the lower limbs, the lateral popliteal nerve involvement. Question is, how do you diagnose pure neuritic leprosy? Go to the next slide. The diagnosis of pure neuritic leprosy, clinical diagnosis is what you see very early stage is numbness with or without ulcers. And earlier you can see numbness. I have an experience of seeing on a pediatrician from my place who complained of only numbness of the lateral two fingers. And at the end of his day, when he started writing prescription, he said that I can't anymore write prescriptions after some time. And when I examined, I found that he was having a pure neuroleprosy. So numbness can be an earliest manifestation. And of course, followed by later on, it can be followed by deformity or muscle weakness can be there. Neuropathic pain with neuritis can occur. And what do the skin show? When the skin does not show any hypopigmented patch, but still if you observe the skin, it can show either xerosis and fissuring. The autonomic disturbances can be appreciated on the skin. Examination of the nerve is very, very important. Now, I'm very sorry to say that most of the junior residents now, they lack the experience and the training how to palpate the nerve and to find out whether the nerve is thick or tender. Remember that the nerve is thick when it becomes 3 times the size of a normal nerve. It becomes thick. And tenderness, of course, this is also very important. The fact that tenderness is to be elicited, especially not only here, but also Professor Patrick taught us that if you see a patch on the face in a child, hypopigmented patch, and when you can't decide whether it is a leprosy or something else, he taught us that gently tap the patch, and if the child the winces with pain, that means it could be leprosy. And that is again because you have the tenderness of these cutaneous nerves, which can be elicited by just simply tapping the lesion. A silent neuritis can occur. A very interesting observation was type 1 reaction is not at all common in pure neuritic leprosy. It is very, very rare in pure neuritic leprosy. And even if it occurs, it is very difficult to differentiate from the without reaction and with reaction. Next slide, please. Next slide. So to go on, the skin lesions along the distribution of the nerve is hypostatic or anesthetic. You don't see a hypopigmented patch with anesthesia, but there may be some sort of loss of sensation just around the thickened nerve. That's what you can see. But autonomic disturbances and changes can occur. The nerve can be nodular, it can be beaded, or sometimes can be abscess formation can occur. It is very, very important to palpate the nerve only not at that side, but just follow the nerve and find out how far the nerve is thickened. Very interesting article appeared on pure neuritic leprosy, whether they can develop skin lesions. And the answer was skin lesions sometimes can develop later. And they may develop skin lesions during the reaction also. Next slide, please. This is what you can see. And the pure neuritic leprosy with some sort of autonomic nervous system disturbances, autonomic changes on the skin, and where you can appreciate the dry skin. Next slide, please. But this is next slide. So complications can occur in the form of an abscess in the nerve, a sensory deficit, or grade 1 or grade 2 deformities, which are very, very important as far as pure neuritic leprosy is concerned. Next slide, please. And the incidence is very high. And this could be a silent shelter. What you see is a thickened nerve, a beaded nerve, you can see. And if it is on the lower limb, it doesn't matter. But it matters a lot because it can produce a grade 2 deformity. But if it is only a great auricular nerve, which is enlarged like this, even though there may not be any problem immediately, but sometimes that can be a shelter for the bacteria and which can later on get disseminated throughout the body. Next slide, please. And As you see here, sometimes this can be an infrequent inauguration of pure genetic leprosy, and where you see only atrophic changes and followed by atrophic ulcerations. The atrophic changes are mainly because there is loss of sensation in that particular area. So when you see a thickened nerve, and when you observe the loss of sensation, which is pertaining to the distribution of and you suspect pure genetic leprosy, and your clinical acumen of picking the enlarged nerve is very important. Next slide, please. But how do we investigate such cases? Of course, the gold standard is doing a nerve biopsy. Nerve biopsy is done in most of the institutions. It is done, and sometimes it can be done outside also. But again, a biopsy, always biopsy a sensory nerve, because if you biopsy a motor nerve, the patient may develop paralysis after that. So for that matter, some people take only a few fibers of the nerve and not the whole nerve. That's called a sliver biopsy. Fine needle aspiration cytology can be done. PCR can be done only in special institutes. PCR can be done. And when I inquired about the PCR, it costs around 1,500 to 2,000 per patient, and it can be done only in very special institutions. But what is very important is nerve conduction studies can be done, which can show the decreased amplitude of the sensory and motor potentials. But this is not only, you cannot make a diagnosis 100% of leprosy mainly on seeing the decreased amplitude of and sensory motor potential, because it can be common for most of the diseases. Next slide, please. So to overcome this, now people have now they, they they have more experience on this high resonance ultrasonography. As Professor Sapley was telling, that the high resonance ultrasonography could easily pick up an increased blood flow. That's very important. Take home message, I stress that increased blood flow is found in high resonance ultrasonography, and so that is going to be a very useful tool for the confirmation of diagnosis, not for the diagnosis. Once you diagnose as a clinician, you confirm the diagnosis by doing the laboratory investigations. Next slide, please. And finally, we come on to the last stage. Next slide, please. Next slide. I will quit this. Yeah. Yeah, I think the Indian dermatologist got a lot of lady dermatologists into the board, and you can be very happy to see this Angel Bay, and who was the first PhD awardee in the Southeast Asia, and she practiced actually anti-leprol. She brought for the first time in Southeast Asia. So you can be very proud of that, and the treatment of leprosy and started from various things, and from the lamb's blood to now, of course, we know about the latest one. Next slide, please. The multi-drug therapy for leprosy. But the question is whether you have to give a paucibacillary therapy or multibacillary therapy. But now we give uniform MDT has been accepted. So we give all three drugs, because we do not know, unless we are sure that the other nerves are not involved. If it is only one nerve is involved, then you can try the paucibacillary leprosy. But we have found some of our studies, we have found that even for a paucibacillary leprosy, the multibacillary drugs, the MDT, MB, actually works better, and they quickly they are relieved of the symptoms. So in such situations, you can always vote for the uniform MDT, and where you give all three drugs, and rifampicin, dapsone, and clofazimine. And when I don't get dapsone and clofazimine certain times, then I give rifampicin, ofloxacin, and minocycline. So this combination also can be given, and always when the nerve is tender, always start corticosteroids at a very early stage. Very important to prevent the type 1 or type 2 deformities in leprosy, and you have to start corticosteroids. Sometimes the patient still continues to have pain even after the treatment. Then at that stage, you can give tricyclic antidepressants. Self-care, daily inspection, application of neem oil is again very cheap, especially because we know that leprosy affects mostly the lower socioeconomic group of people. So you can ask them to apply just the neem oil, and that detracts the insects. And this has been a nice study conducted at Gudiyatham in Vellore in Tamil Nadu, and they found that neem oil application goes a long way in prevention of the trophic ulcers in leprosy. Next slide, please. Last but not the least, next slide. Yeah, we have to respect these great surgeons, and especially who have done a lot of surgical work in leprosy and then brought back the normalcy in such patients. And two such people I can mention here because of lack of time. And one is Dr. H. Srinivasan, a full-time orthopedic surgeon at CLTRI Chegalpet. And the other one is my favorite person, Professor Paul Brand, Dr. Paul Brand, who worked in Karigiri until his lifetime. Next slide, please. So I hope it is very, very clear. So always remember that don't think that pure genetic leprosy is for others. It is for you to diagnose. And remember that it's very simple to diagnose, and just palpate the nerves. The nerves are thickened and there is loss of sensation over the in the area of supply of the nerve. And these are the two key points in making the diagnosis. And if you have the doubt, then probably you can go in for an high resonance ultrasonography. And if as Professor Saple pointed out, when you have the doubt also, you can always give the patient a benefit of doubt, the multi-drug therapy. You can give all three drugs you can start, and the patient should become better and with your treatment. Thank you very much.
Dr. Prasad, it was very nice presentation. It's short and sweet. You have made it very clear that neural leprosy is very difficult to diagnose, but one of the clinical findings you have given along the nerve pathway, look for the loss of autonomous, like loss of perspiration, the hair, and the texture. Look for that. In investigation, you mentioned that PCR has to be inculcated in our practice to make it, and the high resolution ultrasounds. And of course, rehabilitations and the treatment about the role of corticosteroids. But I just share my experience. Any patients come where I'm suspecting lepra reaction type 1, usually I give ofloxacin, clofazimine, and isoniazid for first 6 months. And after that, I started Epsom. That is usually my experience. So I thought, but before that, I would like to ask a question. What is the specificity and sensitivity of PCR? Because that is very important. Yeah.
Yeah, PCR has got specificity and of more than 90% and sensitivity of more than 85 to 90%. The results can vary, but only thing is, as you rightly said, it does not have 100% specificity.
Okay, thank you, Dr. Prasad. And please wait for, if you can wait for the question at the end, that will be very nice.
Sure,
so
definitely.
We'll go for the next panelist. Our next panelist is Dr. Biju Vasudev. Dr. Biju Vasudev has been introduced properly.
Sir, Dr. Taru Garg.
Pardon?
Actually,
or
sir,
you
it is Dr. Taru Garg, actually.
Okay, you go ahead. Yeah, okay.
So is it okay, sir? Because
yeah. Go ahead. No problem. Because
so I'd like
there is no
invite
problem.
Dr.
Yeah, no problem. Sorry.
Yeah. To she'll be speaking now on recurrent vulvovaginal discharge, because this is something quite a problem in our setup. So over to you, Dr. Taru.
Good evening, everyone. Thank you, Dr. Rashmi, for giving me this opportunity, and thank you, Dr. Saple, for giving me useful inputs for this talk. So vaginal discharge, is it really a domain of dermatologists? Do we really get, patients of too many patients of vaginal discharge other than for STI? So most of the time, the patients land up in gynecology OPD and are referred to us, especially if there is involvement of vulva in the form of any genital dermatosis or any changes in the vulva, or if it is recurrent, a dermatologist opinion is required, or if they want to rule out STI. So normal discharge, we know, is floccular in consistency with acidic pH. And lactobacilli is an important protective mechanism to prevent the vaginitis or any inflammation. Vaginal discharge is distressing and a subjective symptom, and we know what is abnormal vaginal discharge. It can be physiological or it can be pathological. So what leads to recurrent vaginal discharge? So it could be because of incorrect initial diagnosis. It could be because of incorrect or inadequate therapy. It can be because of coexistent or mixed etiology. There can be organism-specific issues such as resistance, or it could be patient-related issues such as immunosuppression. So a systematic approach is required for the diagnosis and the management of these cases. So the causes of recurrent vaginal discharge could be same as that for vaginal discharge, but we have to look for the other risk factors. So these could be non-infective, infective causes, including STIs. Then there are some rare causes such as non-infectious vaginitis, which can be caused by genital dermatosis such as lichen planus, or it could be seen in postmenopausal women as genitourinary syndrome, or desquamative inflammatory vaginitis. Sometimes even psychosexual problems or depression, patients with these problems can present as vaginal discharge. We have come across a patient who told us that her discharge responds to augmentin, and then she was suffering for bacterial vaginosis, bacterial vaginitis, which is caused by beta hemolytic streptococcus species. Then there is a rare condition called cytolytic vaginosis. I'm discussing all these because in rare instances, when you're treating this thing, then these causes rarely can be responsible for recurrence. So this is basically due to increase in concentration of the lactobacilli, atrophic vaginitis, which occurs in postmenopausal women, allergic or irritant vulvovaginitis. This is an important cause, and we have come across again in a 9-year-old girl who presented with recurrent vaginal discharge and was on patch testing, was found to be allergic. Then this was a study. So vaginal discharge can occur in children also. So in this 110 patients were enrolled, and the commonest cause of the discharge was vulvovaginitis. And other causes were foreign body, labial adhesions, vaginal agenesis. And this is another study which again showed that in 90% of the patients, the discharge was pathological. This was again in children, and the most common cause was vulvovaginal candidiasis. So what are the predisposing factors? So as we know, we take the history also, any antibiotic use, prolonged vaginal douching, which disrupts the vaginal flora. Then it could be tight-fitting clothing. Removal of IUCDs has been found to cause improvement in the recurrent vaginal discharge. Sometimes there can be concurrent STIs. Then there can be immunosuppression or in the form of immunosuppressive disease or the intake of drugs. It can be organism related, as I mentioned, so the organism can be resistant. So what is the approach to vaginal discharge? Approach for the vaginal discharge, we should take a detailed history. We should do a thorough examination, including we should look for the external genitalia, whether there is any evidence of concomitant STI, any ulcers or any other lesions which are present, which are giving rise to this vaginal discharge. Then investigations, the pH should be seen whether it is alkaline or acidic, which is important. Vaginal and endocervical swabs should be taken to rule out various pathologies. Then fungal culture and sensitivity is important when we are suspecting it to be because of Candida, and to look for the sensitivity and the organism. Then other blood investigation should be done to look for any concomitant systemic disease. Ultrasound abdomen is required to rule out PID. So vaginal discharge, we know the management. If Amsel's criteria is positive, the patient should be treated for bacterial vaginosis. If motile trichomonads are present, then it should be treated for trichomonas vaginalis. And if fungal pseudohyphae are present, should be treated for candidiasis. Endocervical discharge, we know the causes. So here I'm just focusing on 3 important conditions leading to vaginitis, which we often come across in our STI clinic. So these are vulvovaginal candidiasis, bacterial vaginosis, and trichomonas vaginalis. And we are very well aware of the symptoms of these 3 conditions. So we can differentiate them on the basis of symptoms and signs. So this is grayish white discharge in cases of bacterial vaginosis, clue cells. So recurrent bacterial vaginosis is defined as 3 or more episodes in 12 months, and recurrence can be seen in significant proportion of patients. There can be various risk factors, including use of hormonal contraceptives. It has also been suggested that formation of a vaginal biofilm can be one of the factors in recurrent bacterial vaginosis. So the regimen is same. These are the CDC guidelines. So it is same as that for the first episode of bacterial vaginosis. These are the alternative regimens. However, when there are multiple recurrences, patient requires maintenance treatment, and for that, metronidazole gel can be used twice weekly for 4 to 6 months. And if the patient doesn't respond to even this, then the oral metronidazole or tinidazole is used for 7 days, followed by intravaginal boric acid pessaries, and then followed by this suppressive treatment by metronidazole gel. Monthly, if the patient, the alternative regimen is monthly oral metronidazole 2 grams. It's a high dose along with fluconazole 150 milligrams monthly. Again, treatment of partner is not required in recurrent bacterial vaginosis and in vulvovaginal candidiasis. Recurrent vulvovaginal candidiasis, it affects 5 to 8% of women. And these are the various risk factors, as I have already detailed. And this is a typical cottage cheese appearance of the discharge. And then this recurrent comes under the category of complicated vulvovaginal candidiasis. So in the management, it's important to eliminate the risk factors. It is important to do a culture, which is very important. And these are the pictures showing culture plates. So culture is, it has specificity of more than 99%. And then for the medical management, longer duration of initial therapy is required, topical in the form of clotrimazole pessaries for 7 to 14 days, or 3 doses of oral fluconazole, followed by maintenance therapy, weekly dose of fluconazole. In case of fluconazole resistance, when it is detected on culture, then non-fluconazole azole regimens are used as first line therapy, which could be itraconazole, amphotericin vaginal creams, which is available. Intravaginal boric acid capsules for 2 weeks have also been recommended. They are being used by some people, but I have not used them as these are not available easily. Then intravaginal statin pessaries have also been detailed as a treatment, but again, these are not available. Probiotics really do not play a great role in prevention of these recurrent infections. In fact, I have tried oral capsules containing lactobacillus, but these are not of much use. Then most cases of persistent trichomoniasis are due to either reinfection or poor adherence to the treatment. So the another cause for this recurrence could be antimicrobial resistance, which is seen in 4 to 10% of the patients. The recommended regimen is again same as we treat the first episode. These are again CDC guidelines. In case of treatment failure with metronidazole, 2 grams single dose is used. Initially, for the first time, if it is used, then it should be given for 7 days rather than single dose. And then if it is also, not working, then higher dose can be given for 7 days. And when the nitroimidazole resistance is suspected, in those cases, alternative regimens are intravaginal paromomycin in combination with this tinidazole, which is again not available. And even intravaginal boric acid and nitroxanide has also been used, and the presumptive treatment of partner is required in these patients. So the take-home message is, it is a relatively common condition and constitutes a challenge. However, systematic approach will result in positive outcomes in most of the patients. It is important to establish the correct diagnosis, and it should have a multidisciplinary approach, and the coexisting pathology should be ruled out. These are the references. Thank you so much. I would like to thank Dr. Aishwarya for helping me, and she's doing thesis on recurrent vulvovaginal candidiasis in our department. Thank you so much.
So thank you, Dr. Taru. I think that was a very pertinent presentation, because vulvovaginal, discharge is something that can be very debilitating to the patient, and it can significantly, reduce the quality of life actually. For people getting it, it can be quite bad, for the quality of life. It's kind of very unpleasant, the entire thing. So I just one or two questions that I'll be taking. One is that we do see, because we have a hospital, the Kalavati Saran Children's Hospital, with lots of children in them, which we have a special pediatric dermatology clinic also. So what is your experience about vulvovaginal discharge in children? They are difficult to handle, when they have this kind of a discharge, and their causes are quite different. So what would you like to say about that?
most important cause again in children is vulvovaginitis, especially due to candida. So most of the cases which I have seen are because of candida infection. However, foreign body has to be ruled out in these patients, and even streptococcal infection. If it is very tender, painful, then the streptococcal infection can also give rise to this kind of discharge in these patients.
So I think that's important to emphasize that it's not something to worry about. It could be even streptococcal infection, and even foreign bodies, because that is something that one has to just think that has been there. What is your experience of treating, recurrent vulvovaginal candidiasis in general? Because that is the most common thing that plagues, women.
Very true. So as I mentioned that we are doing a thesis, one of the postgraduate student is doing thesis on this in our department. And what we have found that these patients, most of the patients, the organism is Candida albicans only, and non-albicans species is not very common. And these patients, and we have found resistance to fluconazole also in these patients on microbiology. However, clinically, these patients who are resistant on investigation, even those patients, they respond to fluconazole. And we are using 3 doses of fluconazole in these recurrent patients, and they respond very well. And in the patients where we have found that non-albican species is there, so we are treating those patients with amphotericin B vaginal gel, which is available, and those patients, they respond to it. But as soon as I said maintenance, few patients, what happened that when we have stopped the maintenance treatment, that is monthly fluconazole, they have a recurrence, and those cases, they again require the same course of treatment. So but that happens.
So amphotericin gel also should be continued, ideally. That would be good.
Yes. So, yes, that is for non-albican species. So we straight away, we don't go for amphotericin B.
Exactly.
We go for non-fluconazole, this thing, itraconazole we have tried, cetaconazole vaginal pessary, they respond to that.
Right.
And monthly cetaconazole vaginal pessary, we have also tried in recurrent cases. And boric acid, some people are trying, but we tried to get this boric acid, but we could not. Yes, so some of the pharmacies are preparing this, so we are also trying that. Our pharma department, if they could prepare it for us.
So thank you so much. We'll take up rest of the questions later if they come up.
I think Rashmi, I'll have 1 or 2 comments on this.
Yes, over to you, Dr. Saple sir, because I think next is with Dr. Biju. He wanted to go.
Yeah. Before that, I would like to have some comments on Dr. Taru's talk. See, I'm very happy you bring to the fore about the clinical failure, because we used to get a patient of esophageal candidiasis, I'm talking about 93, 94, and we used to say they are unresponsive to fluconazole. And we used to give this antiretroviral, their CD4 count is to come up and they used to respond. So this term was coined in 93, 94 by us in our department, but was not accepted. But I'm very happy now by 2000, the American people, they accept that as a clinical failure. So what we are dealing is a clinical failure more than the real resistance. To call a resistance, there has to be change in the gene. That is very, we have to demonstrate. Number 2, Taru made it very clear. Usually this is the problem can sorted out by the dermatologist better, but unfortunately there is no sensitization done in the medical faculty. The dermatologists are better to, they eventually they go to gynecologists, but our dermatology has to go out the responsibility to sensitize the medical faculty. These are the cases are handled better by the dermatologist than the gynecologist. And in about 10%, we require the teamwork. So we have given this message. Thank you for that. We'll go for the next panelist, Dr. Biju Vasudev. Dr. Biju, about this methotrexate, we are going to ask question you on methotrexate, because methotrexate has become, the drug is very commonly used, especially in psoriasis. Even the world like developed world, methotrexate is considered one of the main drug in managing psoriasis. Of course, it can be used in other immunological disorders. I remember in 94, I presented first paper, use of methotrexate in psoriasis about 100 and its toxicity. So I remember my teacher used to say, that whenever you're prescribing drugs, doesn't matter if you are not helping patient, but do not harm patient. That means do not take care of side effects. So can you share your experience about acute toxicity of methotrexate?
Yes, sir. Yes, I'm coming to my presentation, sir.
Yeah.
Yes, you're able to see my screen, sir?
Yes, yes, yes.
Yes,
Okay.
very well.
Thank you, Rashmi ma'am and Saple sir, for this opportunity. It's great to be on this session. So my topic is acute methotrexate toxicity, and I was discussing it because I've came across this case, which I'll be discussing. This was a 70-year-old male who was a resident of Raebareli, and he was a known case of diabetes, hypertension, and Parkinson's. So he came with basically history of psoriasis since the last 2 years, and since the last 7 days, he had oral ulcers and ulceration of the skin lesions. So the ulcers were causing him difficulty in swallowing, and also, of course, there was ulceration of most of the pre-existing skin lesions. The treatment he had taken over the 2 years, he had taken a lot of medication, even methotrexate weekly. He had also taken injection secukinumab. And since the last 2 months of exacerbation, he was placed on weekly tablets. And when we took a history, he was basically having a history of taking methotrexate instead of the weekly dose. By mistake, he was taking it, accidentally, he was taking it daily for the last 1 month. So he had a cumulative dose of taking methotrexate 225 milligram in the last 1 month. The known case of hypertension and diabetes was being managed with the drugs, and he was also a case of Parkinsonism on Syndopa. On examination, he had tachycardia, he had pallor, systemic examination was fine. And when we examined the skin lesions, he had these plaques which were ulcerated. So you can see the ulcerations, you can see they were not very deep, but superficial ulcerations. You can see the plaque here with erosion, these fissures on the scalp, and the oral lesions. When we investigated him, we found pancytopenia, serum bilirubin was raised, AST-ALT2, and also the blood urea was also raised. Albumin was low and urine pH was acidic. So we diagnosed him as a case of acute methotrexate toxicity with erroneous dosing, cutaneous ulceration, mucositis, pancytopenia, deranged liver, and renal functions. He was admitted, vitals were being monitored, methotrexate was stopped, urinary pH was monitored. He was hydrated with normal saline 150 ml per hour, and urine was alkalized with citralca 15 ml 8 hourly. And the rescue in the form of injection leucovorin was given 15 milligram IV 8 hourly for 5 days. He was also given injection augmentin and also topical therapy in the form of saline compresses. And for the mucosa, he was also given Inocort mouthpiece. So folinic acid rescue was what we did in this case. We all know the pathway. Here the folate converted to dihydrofolate and then to tetrahydrofolate. And we all know methotrexate acts at the step of dihydrofolate reductase. And what we do is folinic acid is, or the leucovorin is, that we provide the tetrahydrofolate. So these stores are not depleted then. So the dose usually is given 6 hourly to 8 hourly, 15 to 20 milligram doses. We're ideally supposed to monitor methotrexate levels, but it's not available most of the places. So what we do is basically the total dose of folinic acid we give over the duration of 5 to 7 days should be equal to the total dose of methotrexate which has caused the toxicity. So that's a rough indication. Hydration, as I earlier said, fluid input, urine output be monitored. The alkalinization of urine ideally should be done with sodium bicarb 40 to 50 milliequivalents per liter of IV fluid, and this reduces the risk of the intratubular crystal formation. Urine pH, as I said, has to be maintained more than 7. Now, there is something new available which is called as glucarpidase. This is an enzyme which cleaves methotrexate into non-toxic metabolites. So, this is especially useful in people with impaired kidney function, where the methotrexate clearance by the kidney is also delayed. It's a single dose, 50 units per kg given over 5 minutes, and it reduces plasma methotrexate concentration by 97% within 15 minutes. So it's a very effective medication. However, the problem is it has no effect on intracellular methotrexate concentrations. It has effect only on the plasma. So the folinic acid should continue to be given. In addition, you give glucarpidase to reduce the levels of methotrexate in the plasma. So the myelosuppression which occurs due to methotrexate, you can manage with antibiotics for the neutropenia. You can get transfusions with packed red blood cells and platelets, GMCSF if required. Oral care in the form of soft food and liquid diet, saline rinses, and of course, care of the eroded psoriatic plaques. Now you can see this patient, he even by 2 weeks, you can see it slowly the hemoglobin is rising, the counts are coming back to normal. So this slide I've put to show that the response is going to take some time to occur. So do not basically stop the fulinic acid fast, or also do not basically you titrate it with your counts and you expect that it will take some time for it to come back to normal. So these were the lesions you can see here. After 2 weeks of therapy, the psoriatic plaque, the erosions have vanished, the fissures on the scalp have gone, and the risk factors for methotrexate toxicity are basically hypoalbuminemia, renal disease, elderly patients, drug interactions, I'll come to later. And if you're not giving folate to the patient along with methotrexate, errors, as we've seen in this patient, the first 4 to 6 weeks of therapy, you should be careful, and genetic polymorphism. So these are the drugs, if you're giving along with methotrexate, always be careful. Salicylates, NSAIDs, sulfonamides, phenothiazines, phenytoin, and tetracycline. So we all know the effects which can occur. So most of it occur in our patient too. In addition, of course, it can cause also acute pneumonitis. That's all we have seen also occurred in our patient. Now the dosage of folic acid, this is the table which gives the, like, it is based on when the last methotrexate dose was given. And of course, as I said, the methotrexate plasma concentrations. Most of the time, this is not available to check. And as I earlier said, the total dose of folinic should be equal to the total dose of methotrexate, which is causing toxicity. So the take-home messages from my basically the lecture is that acute methotrexate toxicity can be life-threatening. Now, this is one of the dermatological emergencies we face. It is important to recognize and treat it early. Accidental overdosage, as in this patient, can occur, especially if you have not counseled the patient properly. If you give folic acid along with methotrexate, the methotrexate, you ask the folic acid to be taken 5 days a week. The patient, instead of taking folic acid 5 days a week, takes methotrexate 5 days a week. So these are common issues which have been sometimes methoxyline and methotrexate are confused. So all these are things which can errors and which can be basically avoided if we counsel the patient properly. And predisposing factors always to be kept in mind. If you have a patient who has acute renal failure with drugs which can concomitantly have interactions, you have to be careful. And as I said, the most important thing is how to counsel the patients on taking the drug in a prescribing methotrexate, and regular follow-up. You should ideally have the first dose, of course, the first week testing, and then 2 weekly at least for the first 2 months, and then you can shift to monthly and 3 monthly. So this is what I would want to convey. And acute methotrexate toxicity, we should have a suspicion and of course treat it as an emergency. Thank you so much.
Yeah. Thank you, Dr. Biju, for your nice presentation. Is a good case. I remember long back, almost 25 years before, I lost one patient who was 78 years old, where the methotrexate was started. So one of the question I would like to ask, you know that folinic acid, if you start within 48 hours, then only it works. So our diagnosis should be within first 48 hours. So how do you diagnose
Yes, sir. So,
within 24 hours, because you have to diagnose within 24 hours.
Correct.
Yeah.
So what I would say is, when you have a psoriatic patient who's on methotrexate, if you have a patient reporting with oral ulcers, that is when you should start the suspicion. If there's any oral symptoms, of course, you think of a drug reaction first. So here you think of methotrexate, and the patient says he's getting weak, or when you test his hemoglobin, you find it to be low. So these are the initial things. And of course, if the skin lesions start ulcerating, then you definitely have a clue. So this is how you, and of course, if the patient is on regular follow-up, he's coming to you every 2 weeks, the initial period, you're likely to pick it up fast. So this is how you diagnose early. And as soon as you diagnose, start your folinic acid. Do not wait for anything else, because that is going to be a lifesaver.
Yeah, I agree with you. But usually the ulceration occurs after 24 hours, not before that. So we have to diagnose before 24 hours. So how do you diagnose?
Yeah, in that case, even actually, if you have a patient who says he's taken more doses accidentally, or he complains of lassitude,
that's how you can suspect. Yeah.
Yes, if he complains of weakness, If he says that something, he's kind of developing a sore throat, so that kind of thing, or if he feels he has a solitary ulcer in the mouth. So these are kind of early
But
symptoms.
again, ulcer, everything, it takes more than 24 hours. Anyway, I'll
Yes.
come to the point.
Even urine is
As you
important.
said, this toxicity can occur because the idiosyncrasy also, it can
Yes,
happen
sir.
with a small
Yes.
dose, but
Yes.
usually the cumulative doses we have to be very careful, as you
Careful,
said.
yes.
But
Yes, sir.
ideally, if you do WBC count within 24 hours, because what is important in the bone marrow. So always advise this patient, if you are suspecting, as you said, they are coming with the
Yes,
large
sir.
doses for a long period they are taking, WBC count is very important to
Yes,
diagnose
yes.
within 24 hours.
Correct.
This is one of the things. And secondly, usually at the elderly patient, as far as possible, we try to avoid, because the bone marrow suppression can go into septicemia, and usually they die of septicemia more than other things. Anyway, thank you very much for
Okay, sir.
presentation.
Thank you so much.
So now we'll slightly deviate the program. Now this program, yeah. Next question I'm going to ask Dr. Rashmi Sarkar more than the panelist. Rashmi, is okay with you if I ask question?
Yes, sir.
Yeah. Now that you are contesting election for the president's post, and we would like to know, in fact, all audience like to know, what are your views about the IADVL, or what is your vision for IADVL, future vision?
Thank you so much, sir. I think standing for these elections has been a well thought of, thing. It hasn't been something out of the blue. I've been thinking about it for quite a few years, and I've been working on that. So, in the same way, this vision is also something that I have discussed with a lot of people, both youngsters, middle level people, as well as seniors, as well as people from all different kinds of cities before I brought it out. So, I thought about the vision, brought it back somewhere in April 2020. So, mine was the first vision to go on board, and it was structured according to what people want or what people think they lack. So, what I'm looking for something is something that is robust yet practical, because I don't think there's any point in saying something which may not be doable. Because I know that, circumstances can change, like COVID came up. So, something like this can happen. So, if you allow, sir, I have just one slide to show so that people can focus, and I'll speak it out. So, because it. So, in short, I'm going to tell you my vision, which is a 9-point agenda. The first is, these are all words taken from Sanskrit. As you know, sir, I often discuss, about Sanskrit, the Mahabharata, everything, it has a lot of significance in our life, like many of the seniors. Dur Dharma, which means bringing e-dermatology to the tier 2 and tier 3 cities in India, and also making centers of excellence in teledermatology in India. Now, I think COVID has made us realize that teledermatology plays an important role. But what is very much on the back foot is the tier 2 and tier 3 cities. We need to involve them more. The second thing would be making Dermacon more reasonable and affordable to the common members. I have never said that it should be free, because I think even IIT thinks that Dermacon is very important, for that. So in order to get something, it is important to make it reasonable and affordable, and that is what we are going to strive on. Shiksha Dharma, Shiksha or education. And what is the need of the hour is to create post-MD fellowships in dermatology, both with MCI and DNB. This was already taken up, sir, in 2014 and 15 when I was the secretary. It's ongoing, but we need to bring it on board so that we have recognized post-MD fellowships in dermatology with dermatosurgery, cosmetic dermatology, and pediatric dermatology. That is the need of the hour. People don't have to go here and there. Shuddha Dharma, Shuddha or purity. Quackery has been a very plaguing issue. And so we need to work on two fronts. One is to create a kind of a white paper or a position paper What is quackery, first of all? What do we define as quackery before we present it to the government officials? And secondary is also to create awareness in the common public by using social media and media. Who is a true dermatologist? Just like we created awareness with steroids, we need to do the same. Fifth is Shakti Dharma, Shakti, which means power. And this is to make IITVL one of the biggest center of quality care in dermatology. How do we do that? By bringing accreditation to even the smallest private centers, and that could be done with agencies like NABH. And we also need to train the staff in handling dermatology by co-trainers. Sixth agenda is Vishwa Dharma. I think because I've been there working in the International Society of Dermatology, Women's Dermatologic Society, Asian Society of Pigment Cell Research, we need to bring IITVL to the forefront in global dermatology. Seventh is Bhavishya Dharma, Bhavishya or the future. What is IITVL without a future? So we must create a leadership guild for the youngsters, number one, for the middle level dermatologist who may not have realized what is good for him or her, most importantly, the women, and also senior dermatologists who may not have come to the forefront at that point of time. Eighth is Guru Dharma, Guru or our teacher. We are nowhere without the teacher to arrange a formal exchange program between the seniors and the younger dermatologists. We really need this. This can be done without, really getting too much, spending too much money. Ninth is most importantly, post-COVID task force. We are going to be reeling under the COVID for the next 2 years or so. What is important? We need to work on the mental health of our dermatologist fraternity, safe practices in practice, both for themselves as well as the staff in the clinic, financial way forward. We need to show the way and facilitation of medical insurance for dermatologists. Some of these things are doable, and I think, we need to get this on board, and this is something that is practical, and we need to work together to bring this, together for IITVL and for all of us. Thank you so much, sir. So I do hope I get a chance, to implement some of them. Thank you.
Thank you, Rashmi. Now you have got a very good vision for future dermatologists. But my question is how we are going to implement. That is very important.
So I think implementation is going to be a little bit easy now because COVID has shown us a lot of things which were not there before. It has opened up the doors. We already have, teledermatology and online, education on board, which was not there so much. So that is one thing. Carrying it to the tier 2, tier 3 cities, it is just by license. That is going to be easy. Regarding the Guru Dharma and the Bhavishya Dharma, already, sir, when I was the secretary of IITVL, we had the IITVL online mentorship program. This was way back in 2014 when COVID did not exist. And we had already started a pilot project where we had people doing a formal exchange program online with some of the senior dermatologists. So we have it in place. We just need to construct this more. A post-COVID task force is not going to be very difficult because we just need to get like-minded people on board. We've already talked to a lot of people, and we just need to work on things like the medical insurance, getting, safety for the staff, and mental health, which is something neglected. But we're already doing it in the Indian Women's Dermatologic Association. We're working pretty much on the mental health. And that is one thing. And, again, making Dermacon reasonable is going to be around the corner because we can work on ways and means to do this by maybe cutting down of some of the expenditure, not making it totally free, but reasonable and maintaining that particular cost. Now we have two platforms, both the e-platform as well as the physical platform. So I think all these are quite doable, and, we are going to work around that and make it feasible for all the people.
Rashmi, thank you for you have got such a large experience working with the IITVL. So things should not be that difficult to implement.
Yeah, working with many seniors has helped, sir, because I have worked with so many seniors.
Teamwork and all this, as you said, it will be very useful. But is one of my suggestion, for example, as you said, it should be whatever the treatments available should be affordable to the masses.
Exactly.
That's how, because I'm working in HIV with the poor people, we have learned it should be affordable, and that's why That's why we also believe in that. So that is one of the good things. So what is my suggestion here? Try to utilize pharmaceuticals for the clinical study more than just sponsorship. That is one of my suggestion. I think because India, we can do a lot of research. And if you do research, then only you get a value, because the original research has got very high value and that we can do it. So this is one of the suggestion. Now we'll go for the next panelist. Next panelist is...
So very well taken, sir. Very well taken. The IDBL research grants for 50 lakhs were started somewhere in 2014-15 when I was the secretary, and it's very well taken, your suggestions.
Good, very good. So we'll go for the next panelist. Our next panelist is Dr. Abhishek Jha from Patna. Abhishek, we are coming again the management of the common problem. Now this recalcitrant dermatophytosis is becoming nightmare, not to the patients only, but even to dermatologists, because cases are coming either with a relapse, recurrence, partial response or no response. So it's a very big problem. And now it is proved beyond doubt it has become a chronic disease where the cellular immunity is involved. And when the cellular immunity is involved, is the treatment is for the longer duration. And when the longer duration, a chronic disease, the key in success in all chronic diseases is compliance and adherence. And this compliance adherence we can achieve if you have got good counseling. And I heard you have got very good experience about the counseling of this refractory dermatophytosis. So we'd like to hear from you. Please go ahead. Abhishek. Yeah. Shailendra, can you help? Any problem?
Yes, sir. Abhishek, sir, you are on mute.
Good evening, everyone. Am I audible and visible? My slides?
Perfect.
Yes, perfect.
Yeah. Good evening. Thank you, Saple sir and Rasmi ma'am, for giving me this opportunity. I will be speaking on counseling in recalcitrant tinea infections. Most of the time when I'm working at my government medical college, and every day, few patients, they come and they say, ki, sir, itraconazole I have taken fluconazole, I have taken grisophulvin, I have applied laliconazole, what I should do now? So in those cases, we really need to think what we can't say them ki ab dawa nahi dua ki zarurat hai aapko. So we need to think what to do. And what I found in my recent times, that counseling is the part we always miss. Most of my PGs, they will just simply used to write like the prescription they used to give to them. Now what we have done, we have made a leaflet, we have pasted it at the few places. The patients who are educated, we ask them to read them. And if they are not educated, we make sure that we just counsel them properly. So as we all are facing the recalcitrant tinea in our practices, alarming situation according to Dr. Rajgopalan and et al., the 36.6% to 78.4% recent prevalence of dermatophytosis in India, and around 50 to 20% and even more in few practices, our practices, we find the recalcitrant tinea infections with atypical presentation, poor therapy response, chronic diseases, and recurrent infections. These are some of the symptoms we all know: itchy red skin, ring-shaped patches, sticky feet, thick or discolored fingernails, cracking fingernails, bald patches, or hair loss. So what are the factors we are facing recalcitrant fungal infections? One of the major factor is global warming, and others are migration of laborers because they live in the numbers in the small places, increased frequency of wearing of tight clothes, synthetic clothes, obesity, our lifestyle now, the change of the now most of the cases are coming from pyrgophyton megatophytes, and poor compliance, and due to the use of topical steroid and mixed type of creams. So what is the most important in counseling? That is the hygiene. I tell my patients, if you put some rice or something in a place and you just put it for 2 days in a warm place, you see the fungus. So it grows by its own. So you have to take care of yourself. You have to keep yourself you have to maintain your hygiene. So most of the patients in our like in our part, they think that if they apply Dettol or something, it is going to Dettol application or Dettol soap. So first of all, we should always ask them not to apply any antiseptic solution. Dry your body completely after bath, even after going to washroom, after going to toilet, or after any, even in the Muslim patient, I ask them to after wudu and everything, they should always keep their body dry. Avoid tight-fitting synthetic clothes, sharing of clothes, towel, bed sheets, socks. Infection can spread through nails, so we have to keep avoid scratching and cut them regularly. Family members should be always checked, because if one is in the family is having any fungal infection, it is like a ping pong. So one will get cured, another will get it. Then again, the same person will get infected. Avoid self-medication, like most of the patients in our part, they do. They always come with most of the patients, they come after applying any topical steroids or mixed type of creams. And we have to make sure that the patients complete the prescribed course of the medicines, even after the symptoms are gone. I always tell them, my patients, that even if you shave your head, the hair will come back. So you have to make sure that you just don't become a doctor. Let me tell that you are now cured. So this is usually what we get in our practices. Patients, they come, then they will say that I have again got the lesions. That you ask them, did you complete the medicines? They say, no, doctor, the rash and the itching disappeared soon after taking the medication. Hence, I stopped it. I always tell them that I am the doctor. Let me decide that you are cured or not. So always make sure that patients, you have to tell that the skin have different layers. The diseases can be in any layer. So till all the lesions are cured in all the layers, then only you get cured. So please come back, visit me or anyone, and then continue the medications. It may take up to 3 months to get cured. And again, I make sure that even the medicines and the creams, you have to apply at least 2 weeks after the lesions and the rashes, they disappear. So tips to prevent the infection: bath twice a day, preferably in cold water or a lukewarm water. Always wipe, dry, and then only wear clothes. Wet or damp clothes should not wear, never be worn. Clothes should be washed in the hot water, and it should be always put in the dried in the good sunlight, inside out. In the absence of sunlight, you can iron the clothes, but it should be always inside out. Infected clothes should be washed separately. The inner wears and the trousers, they should the socks, they should be separated, washed. Then in the male patients, I always ask the patients to wear boxer kind of or short type of inner garments, and female in bikini type of inner wears. Regular removal of hair on genitalia should be ensured if the genital area is involved. Loose cotton garments should be worn. Jeans, actually, I wear myself most of the time, so it is hard to tell them that you should not wear, but I somehow make them agree that you should not wear jeans. Leggings and jeggings should be also avoided. Then regular wash of towels, socks, pillows, covers, bed linens, caps should be done. No sharing of towels, soaps, clothes, and bed linen. To prefer open wear clothes with cotton socks. Uh, Cleaning of your areas. Females should avoid cooking during day between the 2 dishes. And strict adherence and no topical steroid use. Patients should always inform you if the patient, after taking the medicines, they have decreased appetite, nausea or vomiting. Treatment, you have to tell the patient it will take at least 6 weeks and it can take up to 3 months. So don't stop your treatment on your own. Do not apply soaps for first week. Then after that also you can apply. And antiseptics, as I said, Dettol, Savlon should be avoided. These are the benefits. If the patient is regularly taking bath, the fungal load will be lesser. Okay. And regular laundering of the clothes, then avoidance of sharing of clothes that reduces the transmission to the family members. Treatment of other infected house members will also inhibit the transmit. Avoidance of wearing bands, threads that can recur the infection. Loosening of weight, that can be the groin area and the intergenous areas, they get less sweating, so the patient improves. Then for the avoid pet contacts to have zoophilic infections, avoid applying topical corticosteroids to make sure that they reduces recurrence and atypical presentation, and complete the course to get complete cure. Thank you.
Thank you, Abhishek. Because the counseling is more very important in case of any chronic disease I have mentioned. But here, what is important is the adherence to the treatment. Like when they are taking the treatment, we have to see that the treatment is taking regular, as you said. And as Rashmi Sarkar has mentioned, is one of their vision in future IDVL, it should be affordable. So because of the HIV background, we learn that the compliance adherence is very important in chronic disease. I started working about 4 years back in dermatophytosis, and then realized those patients who are coming to our clinic and they say we are using itraconazole, but it's not working. I said, I'll give a guarantee. We'll start only itraconazole, proper doses and proper duration. And I'll take a challenge. It will work with a good adherence and compliance. But for that, most of our dermatology, as you said, we are very busy. So for example, my clinic, there is a separate doctor. Any patient or dermatophytosis comes, he'll go to the doctor. Doctor will sit in the separate room and counsel that patient 15 to 20 minutes about adherence. And as Rashmi Sarkar said, it should be affordable. Then I started working. Itraconazole, terbinafine, many people could not afford. It's a very expensive drugs. So I started working and found fluconazole is one of the wonderful drugs I'm using for last 3 years. We followed those patients for 1 year. There hardly in, of course, 84% there was no recurrence and no relapse followed for 1 year. But fluconazole has to be given 150 milligram daily. As you said, minimum 6 to 8 weeks. Some patient even 3 months, and rarely in the patient was on immunosuppressive even for 6 months. So thank you very much for contributing your experience. Now I'll hand over.
But after the last webinar, I started giving the fluconazole.
Yeah, and what is your experience?
It is good, sir. But few of the patients came and said, "Sir, ये तो weekly खाते हैं ना?" मैंने कहा refer to Saple sir.
Okay, yeah, that is a good point you brought it, because in the book is given once in a week or twice in a week, and they said there is no response. So if you once in a week or twice a week, you are not going to get response, because if you go to pharmacokinetic of fluconazole starts getting concentrated in stratum corneum within few hours, and it goes up and lasts for 30 hours. After 30 hours, its concentration comes down. So fluconazole, if you are using for dermatophytosis, you have to use second dose in 30 hours, that is 24 hours, that means daily. If you use once in a week, twice in a week, it's not going to work. And that is, I think, mistake many doctors are doing. So use daily. Even we are conducting trials, and I told this FDC, just promoting this Zocon is not going to work. You have to conduct clinical studies. So they have planned 20 clinical study across the country. I hope we'll have result of this study. And thank you, Abhishek. Thank you very much. And I'll hand over mic to Rashmi Sarkar. Rashmi, please go ahead.
Yes, sir. Yes, sir. Thank you, Abhishek. Thank you very much. And now next on board is, Dr. Kanika Sani. And Dr. Kanika is going to talk about something really new and exciting, and that is in vivo cell, suspension technique in vitiligo, because vitiligo is a very important problem in India. We need newer and newer surgical modalities, some which are easy and some which are innovative. And she's going to talk to us about this procedure. Over to you, Kanika.
Thank you, ma'am. First of all, I would like to thank Dr. Rashmi and Dr. Saple for inviting me for this presentation. And I've known Dr. Rashmi for really long, and she has been a true mentor for me. So I have all praise for her. And thank you so much for inviting me, ma'am. So I'll start with my presentation. It's on in vivo epidermal cell suspension for vitiligo. This is a new technique that we have pioneered at AIIMS. And so we know that vitiligo affects people of all races and all colors, and some of the very famous personalities have also suffered from it. And it has so much of a social stigma attached to it that the Time magazine has once run a cover on it, where a photographer has documented the stories of Indian women who have felt isolated due to the skin disorder. And they have been isolated from their families. They have had to leave their homes. They have had to give up their professions because of this condition. And hence, in many of these patients, the ultimate treatment that tends to help them is surgery. So we know that surgery is possible only where the disease is stable and not in active disease. But when we are contemplating surgery, we also have to consider what is the perfect surgical procedure. So we are aware that surgical procedures are of two types, tissue grafts and cellular grafts. Tissue grafts, although they are easy to perform, like suction blister grafting or split thickness skin grafting, they do not require lab equipment. However, they cover small areas and large donor sites are required. On the contrary, cellular grafts, they cover large areas of skin using small donor sites, but they require expertise and expensive lab equipment, and a total setup is required. And these include non-cultured epidermal suspension and the cultured melanocyte transfer. So coming to the perfect surgical procedure, and we pioneered this technique of in vivo epidermal cell suspension, wherein a mini laboratory is created right on the patient's skin, inside the blisters that are formed on the thigh using the suction blister technique. So these are the steps of the procedure. The first is the induction of suction blisters on the thigh. This is, we are all aware of this technique, which has been in use for a very long time. Following this, what we do is that by introducing a needle through the floor of the blister fluid is aspirated out, and through that same needle, trypsin solution is injected into the blister cavity. This is allowed to remain for about 30 to 45 minutes, and it acts on the basal layer of cells. And then after 45 minutes, this trypsinized suspension is aspirated out into a needle, into a syringe. The blisters are de-roofed, and the roof of the blisters is again teased with a forceps to release the remaining basal cell layers into suspension. And finally, the suspension that is available is applied to the dermabrated recipient site. So I have a short video demonstration, which I will see if there is time to show it after the slideshow. But I will first show a schematic representation. So this is the blister that has formed. And we can see these pigmented cells are the basal layer keratinocytes and the melanocytes. The first step is to introduce a syringe through the base of the blister into the blister cavity. And after aspirating out and emptying out the blister, the next step is introduce trypsin EDTA solution into the blister cavity. And this is allowed to remain for another about 30 to 45 minutes. And after 45 minutes, because the body's heat acts as an incubator at 37 degrees Celsius, trypsin gets the optimum temperature to act. And what happens is that these basal layer cells, they come into the suspension. And this is then aspirated out using a syringe. However, we can see that some basal layer cells still remain attached to the blister roof. And for this purpose, the next step is to cut out the blister roof and to take it onto a slide. And we take it into a Petri dish where we have already put the suspension that we have aspirated out of the blister fluid. And then this blister roof is teased with a forceps to release the remaining basal layer cells into the suspension. And this suspension is then aspirated out into a syringe. One intermediate step that is optional is the addition of trypsin inhibitor. So at this step, before aspirating out the suspension, we could also use a few drops of trypsin inhibitor to neutralize the action of trypsin. However, this is not really necessary because the patient's own serum at the recipient site also acts as an inhibitor of trypsin. And so this step can also be circumvented. So these are the stepwise pictures. The first picture shows the suction blister. In the second picture, we are introducing a needle into the blister cavity through its floor. And so we don't rupture the blister, but we only introduce it through the floor. Following this, the blister fluid is aspirated out and discarded. And from the same needle, by attaching another syringe, we insert trypsin EDTA solution. And this is allowed to remain for about 45 minutes, at the end of which we can see that the basal layer cells have started to separate. So these are some of the results of this procedure. We have noticed pigmentation as early as 2 weeks after the procedure, and nearly complete repigmentation in a number of patients by 3 to 4 months. This is another patient in whom this patch was treated with in vivo cell suspension. This is at 8 weeks, and at 16 weeks, there is more than 75% repigmentation. This is another patient. In this patient, these lesions were treated outside by another practitioner, and he had done a procedure of follicular unit extraction and transplantation. So this gave a very poor cosmetic outcome, because hair follicles were transplanted onto a site which is non-hair bearing. So the patient was not satisfied. So in this patient, this lesion we treated with in vivo cell suspension, and as we can see, there is an excellent outcome. Similarly, when we compared the procedure of in vivo suspension versus non-cultured epidermal suspension, the lower lesion was treated with in vivo suspension, whereas the upper lesions were treated with non-cultured epidermal suspension. And at the end of 16 weeks, we can see there is a comparable result in both the procedures. We have also performed microscopy of the blister roof. So this is the blister roof on H&E staining without the trypsinization. And this is the blister roof which we get after the trypsinization has occurred. So we can see that all the basal and suprabasal layer cells have been removed. They have come into the suspension and they are no longer there in the roof. So we have also tried to evaluate the safety of trypsin at the donor site. And we have seen that in these patients, few of the blisters only were injected with trypsin, and the others in the beginning were treated as a suction blister grafting. So we can see that at the end of 1 week, nearly all the lesions, nearly all the blisters have reepithelized completely the donor site. So this technique offers a number of advantages. It is simple and it does not require training in lab techniques. The second major advantage is that there is no lag period or transportation between the harvesting and the transplantation, which is why there is very minimal risk of infection. The blister cavity provides a closed system, which is equivalent to a biosafety cabinet or hood. Trypsin does not have any effect on the dermal tissue. It only acts at the dermo-epidermal junction, and hence there is no interference with the healing of the donor site. And it is because it is rapidly neutralized by the patient's own serum, even if small quantities do get absorbed from the dermabraded site, they are neutralized very rapidly. However, compared to non-cultured epidermal suspension, it does have some disadvantages. One of which is that it is more time consuming. It requires a longer period of time for induction of the blisters, because of which there is a greater inconvenience to patients. However, it still offers a number of advantages, because of which it can be used at the grassroots level, even by practicing dermatologists who do not have a setup which can in which they can easily perform epidermal suspension. So this technique could be very useful in smaller centers with insufficient lab support, and it could revolutionize the surgical treatment of vitiligo, and hence I've shared it with you. So this is Winnie Harlow, who's a Canadian model who has come out with her pictures. She suffers from vitiligo, and finally, let's live beyond vitiligo. I have a short video. If Dr. Rashmi says we have time, then we could see it. Otherwise, if it's clear from the presentation, then we could skip it.
How long is the video actually?
Ma'am, I could do it in a minute or two, like maybe. So
please do it in a minute, because then we'll take questions later. Then that's what we could do then. That's the only thing.
So this is the first step is to create the suction blisters on the upper thigh. So we first anesthetize the area with a mix of bupivacaine and lignocaine. And this gives long-lasting anesthesia. Following this, using 10 ml syringes and 3-way cannulas, the suction blisters are raised on the lateral thigh. And this takes about between 1 to 1.5 hours, sometimes up to 2 hours. Once all the suction blisters have been raised, a needle is introduced into the base of the blister, and and the fluid is aspirated out. And after that, the needle is removed, the syringe is removed, and another syringe containing trypsin EDTA solution is attached, and trypsin is injected into the blister cavity, and it is allowed to remain for about 45 minutes. At the end of 45 minutes, once the trypsinization has happened, this blister fluid is aspirated out. And finally, once the blister fluid has been aspirated out and taken into a Petri dish, after this, the de-roofing of the blisters is done. This is done using a scissor and a sterile slide. The blister roof is taken onto a slide with the dermal side up and the epidermal side down. And later, once all the blister roofs have been harvested, the suspension is prepared in the Petri dish. So this is the aspirated trypsinized suspension, which is loaded onto the Petri dish. And after this, we can see here the cells which are separated out, the pigmented cells. And then the blister roof is transferred into the Petri dish, and with the help of two forceps, just like in non-cultured epidermal suspension, the cells are further released into the suspension. After this, we may or may not add a trypsin inhibitor, and this is the suspension that is ready to be transplanted onto the recipient site. So finally, this is the trypsin inhibitor which is being added. And finally, this is loaded onto a syringe, and it is ready for transplantation onto the recipient site. Thank you.
Thank you so much, Kanika. That
Thank
was
you,
absolutely wonderful. And I think you've not left anything now, to the imagination. They know how to do it. I'll just have one or two questions because we have a few more panelists. One is that, a question which we had even when we were doing a workshop for pigmentary-con, remember?
Yes.
How do you get the trypsin for and all, That
Yeah.
is one important thing.
So it's easy to procure trypsin. It's mainly through two manufacturers. One is Sigma Aldrich and the other is Gipco. So if you go onto their website, it's easy to order it online, or even you can, they have a contact number through which you can find out your local area representative for these two companies, which are Sigma Aldrich and Gipco. So it's easy to procure these, and generally premixed trypsin EDTA solution is available in a 200 ml or a 100 ml bottle. And so that should last you for about 4 to 5 surgeries at least. And the only thing is that once you receive it, you need to make it into smaller aliquots and freeze it. So each time for one patient, you do not need to freeze and thaw the entire trypsin, because then it loses its efficacy. So what you do is you make smaller aliquots and you thaw only the one that you require for one particular patient, and the others remain frozen in your freezer.
Yeah, I think we had ordered ours. I think it was from some place in Delhi, probably the Daryaganj or something, because people had got it and we carried it. I think you people carried it.
Yeah. Yes, ma'am.
So that's an important thing. And what about, can you really do this process without a trypsin inhibitor?
Yes, ma'am. So I mentioned that trypsin inhibitor is a very costly reagent. And we have noticed that even in non-cultured epidermal suspension, we no longer use it. And so also for this procedure, because as we transplant the suspension onto the recipient area, the serum that is exuding out from there after the dermabrasion is sufficient to neutralize the trypsin. So that is why this step can be avoided. We need not use a trypsin inhibitor.
Right. So thank you so much, Kanika. Thanks for being with us.
Thank you so much.
It's been, I know it's...
Rashmi, I got one question from Kanika.
Yes, sir.
About the cost. The cost is affordable or compared to other procedure?
Yes, sir. So trypsin as such is not very costly. So it will cost about 1,600 rupees, 15 to 1,600 rupees for 100 ml. And 100 ml will be enough to be used in about at least 6 to 7 patients. Okay. So the reagent itself is not costly, and because you need just plastic or glass petri dishes, you can use glass petri dishes which can be reused. You need forceps and all the routine instruments that are required for minor dermatosurgical procedures. So hence it is very easy to be performed anywhere.
Okay, thank you, Kanika.
Thank you, sir.
So I'll go over now to the next speaker, Dr. Uday Sidhu. Thank you so much, Kanika. Thanks for being with us. I know it's a
Thank
bit
you,
late.
sir. Thank you,
Thank
ma'am. Thank you.
And before I go to Dr. Uday Sidhu, we do have, one comment, from the audience, and I think that was pertinent, relating to what I had said. This is from Dr. Deepak Shirbhate from Yavatmal. Thanks for being there. Good vision for our IITVL by Dr. Rashmi Sarkar. It's possible only under your able leadership. As a good administrator, we expect good collaboration between IITVL and government for various projects. Best wishes from all IITVL members of the nation. Thank you. Thanks to the entire audience. Dr. Shirbhate too. Thank you. Over to you, Dr. Uday Sidhu. And we are very keen to hear about you about a topic that is very important, and that is periorbital hyperpigmentation. We talk about melasma and post-inflammatory hyperpigmentation, but what we don't talk about so much is periorbital hyperpigmentation. Over to you. Yeah, it's not audible. Hello? Yeah, Uday, it's not audible somehow. Hello?
No, ma'am, we can't hear you right.
Yeah, it's not audible.
Ma'am, are you using headphones? Ma'am, kindly check your laptop is on mute or not.
Yeah, it doesn't show mute, but we were able to hear her back. Not able to hear Uday.
Ma'am, you will have to.
Yeah, Uday,
Yes,
you can leave. Is it okay? You can leave the meeting and maybe come back, rejoin. Yeah.
Yeah, that is another way of.
Yeah. I think you can leave and rejoin. So while she's doing that, should we go over to the next speaker actually?
Yeah, I think we can go for next speaker. Yeah.
So Dr. Sameepa Mukherjee, are you there? Dr. Sameepa Mukherjee, yeah. Are you ready to go? Yeah, you're on mute. Yeah. So next is while we wait for, she's connecting actually. Maybe we'll just give her, just let us see if she connects.
Ma'am, am I audible now?
Yes, you're audible. Yes.
Okay, ma'am.
Yeah.
All right. So sorry for the glitch. And it indeed is a pleasure to be here among such esteemed panelists. And I would like to thank Saple sir for having me here, and I would like to thank Rashmi ma'am for having me here. And I've known Rashmi ma'am for a long time and interacted with her very closely at multiple conferences. And she is my mentor. I'm very proud to say that. And wish you all the very best, ma'am, for the president elections and for the results.
Thank you. Thank you.
Thank you, ma'am. And I would move to my topic, that is the periorbital hyperpigmentation. So eyes are a very, very focal point of facial expression, and they are considered as a mirror of mental and medical health of a person. Periorbital hyperpigmentation is a very common clinical presentation and a very challenging one also in our day-to-day practice. So as a dermatologist, it is very important for us to identify the etiology and plan our treatment according to that. So when we are looking at the etiology, we can classify into two, that is the endogenous and the exogenous causes. In the endogenous causes, we have the familial, the genetic part, And the advancement of age can lead to a depressed inferior medial orbital rim. There can be a loss of subcutaneous fat, losing of the orbital rim ligaments, and a cheek descent, which leads onto a very prominent tear trough and is an important cause. Increased vascularity, systemic causes such as vitamin K deficiencies, anemia, thyroid disorders, renal and hepatic concerns as well. Moving on to the exogenous causes, the ultraviolet radiations do contribute. And a very interesting point to note here is that at times the periorbital dermatitis can be a precursor of either a periorbital hyperpigmentation or a post-inflammatory hyperpigmentation. And fragrance mix and nickel are the top sensitizers. PIH, which can be secondary to the lichen planus pigmentosus, FDE, EDP, we have to look out for those as well. Extension of the pigmentary demarcation lines, especially the type 5. Drugs, such as the ocular hypertensive drugs like lanatoprost, can be the cause. Cosmetics, I think women, especially in India, love to wear kajal or kohal, and lead in the coal can be a contributory factor. Now let's look on to the various classifications. So this classification is been wherein there is 4, that is the constitutional, wherein there is presentation of a little brownish pigment around the inferior medial margins. The vascular one, which can be associated with telangiectasias, and it tends to give it the eyes a bluish pinkish color. Post-inflammatory, wherein there is lichenification present and prominent skin markings. The shadow effect, wherein there is a prominence of the tear trough and can be associated with a periorbital edema. Huang et al. Has classified into pigmented type, the vascular, the structural, and the mixed. The grading is from grade 0 to grade 4. So grade 0 is wherein there's no evident orbital hyperpigmentation. Grade 1, there is minimal. So this one is the grade 1. Here we have the grade 2. That is, it is more pronounced, the pigmentation. Grade 3, wherein all the 4 eyelids margins are involved, the upper and the lower, and it is darker in color. And we have the grade 4, wherein it goes below your inferior orbital margins and goes towards the malar area as well. Coming on to the evaluation. So history taking is very important, should be very precise, and helps to a certain extent to zero on to the etiology or the causative agent of the same. When we're looking at the physical examination, we need to examine the upper as well as the lower eyelids. We need to look if there is an extension which is going beyond the periorbital region. Look for pallor, lichenification, any extra vasculature that is present, and clinical tests such as the eyelid stretch test, the gaze test, Wood's lamp examination, and dermatoscopy are usually contributory to the diagnosis. We can go for relevant investigations if required, looking at the basic blood counts, the renal liver profile, thyroid, and cholesterol levels as well. Very important to conduct the examination in direct light, and photography is very important, especially when we are putting the patients under treatment and to monitor the improvements. Association with other dermatological disorders, such as pigmentary disorders, such as acanthosis nigricans, melasma, amyloidosis, dermatomyositis, should be looked into, and these all do form our differential diagnosis as well. Coming on to the treatment, it predominantly depends upon what etiology we have looked into. And ideally, to have a multimodality treatment approach is the best way forward. So when we're looking at a pigmentary cause, we are looking at options such as topical bleaching agents, which can be hydroquinone associated one or the non-HQ, chemical peels, which includes your glycolics, your lactic acid, salicylic acids work well, and with proper precautions are very well tolerated amongst the patients. We can look at lasers with all the appropriate precautions, such as the Q-switched Nd:YAG. When we're looking at vascular causes, apart from the lasers, we can try out the vitamin K-based serums. And when there is a structural abnormality associated, definitely we have to further step up. Look for, we can go for either a hyaluronic acid filler or surgical methodologies. Here, I'm just sharing a few of my patients with their prior permission. So in this, I have this 40-year-old woman who presented with melasma, the malar region, and it was almost getting merged with the tear trough, and she was very concerned about it. This is just a picture after 2 sessions of the Q-switched Nd:YAG. And in this one, I have a young gentleman around about 28, 30 years of age who did present only with the concerns of toning, especially over the forehead area. That's the pigmentation. And so this is the picture that I'm showing after, say, about 2 sessions of the Q-switched Nd:YAG, which did improve a little bit of his periorbital hyperpigmentation as well. In this, I have a young lady who came up with the same concerns, and you can see that there is a significant lichenification. The skin creases are marked. She did have a significant history of atopy right from childhood, and she was put on serial sessions of starting with lactic acid peels and moving on to glycolics, and she was happy. This is after, say, about 3 sessions of treatment. Here, this lady who just came for facial rejuvenation, she did not have any concerns about how her eyes were looking, but with the laser toning, she improved significantly, and there's a marked improvement as far as the periorbital rejuvenation is concerned. So very challenging to treat in private, in our clinical practice, but a lot of treatment and a multimodality approach works very well. So thank you so much for your patient listening.
So thanks a lot, Uday. That was a wonderful presentation. Also, one of my areas of interest, periorbital hyperpigmentation. I published quite a bit on that. Yes, and you've already, I think, concisely covered the entire topic. Have not left much, but I'd like to still tell you that, it's a very soft area. We are very skeptical about physical modalities. So when you're using a laser also, Q-switched, Nd:YAG laser on an IPL lasers, what are the tips and tricks actually?
A very relevant and interesting question, ma'am, because it's very practical. First of all, I think convincing the patients is itself a very challenging task when we say that, we're going to use lasers right close to your eyes, because they've done their homework and they're very concerned about it. And they do ask, are my eyes going to be damaged? So yes. First, winning their trust, maybe showing them some pictures of the patients that we've already worked on. And the next comes the challenge of an eye shield. Very challenging. At least in my practice, my patients are not very comfortable about the eye shields. So what we do is we kind of really stretch the lower eyelid and work predominantly more onto the lower eyelid as such. And along with that, a treatment modality with the combination agents of an HQ or a non-HQ works very well, starting with a lower fluence, being sure of our spot size and telling them that it is not a one-time thing and they need to be having repeated sessions, and being very careful and follow it up with good amount of ice compresses tends to work well.
So I think that's the trick, and we have to also tell them that there can be medical causes. So we need to rule out those things like medical causes, atopic dermatitis, post-inflammatory hyperpigmentation, because if it is an epidermal cause, nothing like it, it will respond well. And we've shown that simple measures for epidermal, pigmentation, even hydroquinone, 4% hydroquinone, and simple chemical peels work well, whether it's the glycolic acid peel or the salicylic acid peel or the lactic acid peels, does a lot for improving the quality of life of the patient. It may just be a 40% improvement, 50%, but makes a lot of difference to the person, the tired look of the patient, isn't it?
Absolutely, ma'am. Absolutely.
So I think you've done some very good work and all. Any role of moisturizers in, periorbital hyperpigmentation?
Ma'am, especially when we are looking at a matured skin or in a skin wherein there's lichenification, there's secondary history of atopy that is present. So it tends to give a very an immediate upliftment to the skin, but we have to be very cautious that we are giving a bland emollient and go easy with these fragrant mixes and so on. So works very well and even goes on during the maintenance phase.
Right. Thank you so much, Uday. Thanks for being with us.
Thank
even
you,
at
ma'am.
this time. Yeah.
Sure.
So, that was very good. And, because we need to talk on this very neglected topic. And over to you now, Dr. Sameepa Mukherjee. And Sameepa, we are very keen to hear about wet trap therapy in atopic dermatitis.
Thank you so much, ma'am. Am I audible?
Yes, very much so.
Okay. Thank you so much, ma'am, for having me on board. It's my pleasure to be here with all the other panelists. And thank you for allowing me to speak on a topic which is so close to my heart because I follow it every single day in practice. And this is one of the modalities which I feel is underutilized. And I will get going with the presentation. But prior to that, I want to wish you all the best for the elections and the results, ma'am.
Thank you so much, Sameepa. Thank you.
So we jump straight into wet trap therapy in atopic dermatitis. Now, how I view atopic dermatitis is I view it as a chakra viewer because it is the parents as well as the child who get into it without any fault of theirs. And after that, getting out of it becomes extremely, extremely difficult. Are my slides visible? Okay.
Yes,
so when we talk about the chakra viewer for the child, this is how I would like to put it as. Okay, where is I am facing some issues with the movement of the slide. Okay, fine. All right. So when we talk about the chakra viewer for a child, why do I call it as a chakra viewer? Because the child is always under the constant stress because the parents are always sort of fighting, arguing, or discussing things, and the parents are stressed out, and the stress actually reflects onto the child. When the child goes out to play, the other children might just outcast him while playing because he has a rash on the skin, so they would not want to play with him. The child might actually land up missing schools because of the severe flares that the child has during atopic flares. The child has multiple sessions. The child can go into multiple sessions of admissions in the hospitals because of a severe erythrodermic atopic dermatitis. Obviously, he becomes an outcast in the long run because of the skin changes that is happening. And when you are explaining to the parents about the disease, the poor child who's 5 or 7 years old is not really going to understand what's going on. Only thing that he knows is his skin is trouble and he is becoming the trouble for a lot many people around him or maybe to his loved ones. For the parent, it is a different chakra viewer. Why? Because the parents are obviously facing anxiety first, a lot of stress because this is a condition which keeps coming and going, and the child keeps getting sick on and off. Second thing, it becomes a financial burden because every time to go to the doctors, hospitalizations, medicine cost, all adds on to the burden of expenditure. Then they don't know which pathy to follow. They will be confused as to whether it has to be allopathy, it has to be homeopathy, it has to be Ayurveda, because the ultimate thing they are actually searching for is cure. And we know very well that atopic dermatitis, we can only give control. Finally, Google comes into play and it complicates all the issue. Even if you hate it, your parents are going to actually go and read about it, and there is no denials to that. So they are going to have a zillion doubts in their heads. They will be having concerns about the side effects of all the medicines that we give, not to mention that a lot of parents, at least in the urban setup, are having steroid phobia, and it is real. They will look for cure through various medicines, and that will not be available. And when you say that, okay, we can give you control or we can take off the side effects by giving you other alternative therapies in allopathy itself, like wet traps, then the next concern comes that we are so busy, wet trap therapy or any of the other therapy, taking the child for a UVB radiation or a full body narrowband UVB therapy to the hospital becomes time consuming, and we can't do it. So these are the problems that you are actually going to be dealing with when you look at an atopic child. So I always say that whenever we are treating an atopic child, it's a team effort. My prescription is going to be useless if the parents are not on the same page with me. It is still going to be useless if the child is not going to allow the parents to do or execute the treatment that I have given. So all the three of us have to be on the same page, and we need to work as a team. So what happens when we counsel in atopic dermatitis? This is something which we must address on a routine basis. Take time. At least my consultations for atopic dermatitis patients exceed well over 20 minutes to 30 minutes, anywhere between that, depending on the severity of the disease. You need to tell them about the medical condition. You need to tell about routine skincare, the environmental modifications that can be made. How do you really cope with stress? Because stress comes as a part of atopic dermatitis for the parents. You need to teach them about the relaxation techniques and educational means which is available, because invariably they are going to read. So you might as well tell them what is the right thing to read. Now, coming to the challenges that we really face in the routine management of these atopic kids, especially the ones with moderate to severe atopic dermatitis, is the disease control. So how do you do it? What medicines do you initiate for it? How do I control the relapses and the remissions that keep happening, especially in Bangalore, where we literally have a very dry climate. And nowadays we are literally having 3 seasons in a day. So it's very, very difficult because atopy keeps flaring up. We need to reduce the side effects of the medication. So the cumulative effects need to come down. How do we consider the immunization schedules for immunosuppressants? If it's a child below 5 years of age and you want to initiate cyclosporin, immunization is not complete. Your pediatrician is not likely to give you a consent for initiating oral immunosuppressants. That's another major issue. Alleviating anxiety regarding the side effects of all the topical medicines as well as the oral medicines that is available, and how do we reduce the cost burden, because atopy is not going away anytime soon. It is going to keep coming back over and over again. So that is where wet wrap therapy comes in. And I get a lot of questions asking, why do you do it? First thing, it is one of the most simple and easy technique to do. All that it requires from your end is explaining the procedure to the parent by investing some time in it. It is cost effective because it's not going to add on to the cost burden of the patients. You can do it for any age group, right from infantile age group to an adolescent, to an adult. You can do it for any age group. 90%, almost 85 to 90% of the times in my practice, I have seen that it obviates the need for the systemic medications. So these short courses of oral steroids, short courses of your cyclosporin therapy can be avoided if you really learn how to master the technique of wet wrap therapy and utilize it correctly. There are multiple indications, not just atopic dermatitis for it. You can use it for psoriasis, you can use it for airborne contact dermatitis and a gamut of other conditions. There are no real side effects to it. And it also addresses the concern of steroid phobia, because you will not be requiring to give oral steroids for short courses or a tapering course, however you would want to give it when you are doing a wet wrap therapy for the child, because your child will respond very, very quickly. How do we do it? The traditional steps that I've mentioned in the textbooks or in the literature is we soak the wraps in lukewarm water. We give the baby or the child a bath with lukewarm water. We pat dry the child. We apply the emollient. We apply the steroidal cream on the affected area. We make the child wear the wet cloth first, followed by the layer of a dry cloth.
Now, when we talk about the cloth needs to be body hugging so that it remains stuck to the skin so that it's not loosely hanging. Traditionally, it has been left over for almost about 6 to 8 hours, sometimes even overnight for wet wrap therapy. But definitely, that is not the way we do it in my practice, at least. We have modified it, I have modified it, and that is how I use it, which is what I'm going to explain to you. And literature, if you go back and look at the available literature for wet wrap therapy in atopic dermatitis, in psoriasis, in erythrodermic conditions, you would see that multiple meta-analysis has given a data of almost about 60 to 70% improvement better without any side effects in these kids where wet wrap therapy has been used. So the indications would generally be erythrodermic atopic dermatitis, where systemic immunosuppressants cannot be used. You could use it for maintenance, like you need not do wet wrap therapy every single day. You could do it on a every alternate day basis, weekly, twice basis, SOS basis, because there is no real regulation to it. You are not going to do any harm when you do wet wrap therapy. And even I'm using it for managing the hotspot areas to prevent the chances of recurrences, relapses, and flares. When do you not do wet wrap therapy? You can't do wet wrap therapy if an area is actively infected, where you see pustules, where you can see a crusted or an oozing lesions for obvious reasons. Once you have controlled the local infection, you can definitely go ahead and do the wet wrap therapy for the child. Now, traditional methods of wet wrap therapy consist of using topical steroids administered under a layer of wet cotton bandages or garments along with emollients, and they are left over for several hours or even overnight, like I mentioned before. But the problem with this in our scenario is this. We have a tropical climate, so wearing that wet cloth throughout the night or even for 6 to 7 hours may be very, very difficult for the child, and they may not be willing to do so. Second thing, using a steroidal cream under the wet wrap therapy may be a little concerning, because Kundu sir has already mentioned the sides of the side effects of topical steroid abuse, because our topical corticosteroids are freely available over the counter. And probably because of our climatic conditions, it becomes more convenient and comfortable if we land up doing it for a shorter duration. So the modification that I generally use for my patients in my clinical practices, I use a short contact wet wrap therapy. I give it for about 1 hour in the morning, 1 hour in the afternoon or early evening time. I use it only with emollients. My favorite combination is liquid paraffin along with white soft paraffin and light liquid paraffin moisturizer. The reason why I like to use this combination is because Bangalore is extremely dry. You could use a single emollient followed by the wet layer, followed by the dry layer for the wet wrap therapy. Or in some areas, if you want, you could also use virgin coconut oil as your first layer after bath, followed by the moisturizer layer, followed by the wet layer, and lastly by the dry layer. Now, most of the time, if at all we are talking about infants, I generally like to use it. Infants meaning below 6 months of age, I would like to use it only for about half an hour, somewhere around 11:30 to 12 in the morning and around 3:30 to 4, because that is the most comfortable timing. Now, if it is winter conditions, especially if you are up north or something, you could use it even once a day just for about half an hour. You need not even do a full body wet wrap therapy. You could do it for localized areas. If your areas affected are bad, like the areas on your hands or on the legs, you could probably do it only on those local areas. So this is a method which you can modify and suit or tailor it down for the needs of your patients. Secondly, since you are using only emollients, there is generally no chance of a side effect happening at all. Thirdly, the results are visible as early as 48 to 72 hours. Fourthly, it is completely going to reinstill the faith for medications in your in the parents that you are dealing with. And finally, it is a method which you once have taught the parents, and after that you don't need to worry, because they themselves will tell you that doctor thoda sa badhta hai, so we start on wet trap therapy and it comes down on its own. So that is something which you are going to benefit from. So just to give you a series of patients, I will just discuss about 3 patients. The reason I have taken these patients is because these are certain areas of the body which are a little difficult to handle. So this was again a child 6-year-old with severe atopic dermatitis, had done all possible PETs and come to us, and they were not willing for oral medicines whatsoever. The father was a pharmacologist and he didn't want oral medicines apart from anti-allergics. So we said, okay, we counseled the parents for wet trap therapy. We did wet trap therapy with just liquid paraffin, and I used white soft paraffin and light liquid paraffin combination for the emollient purpose. Now, one tiny trick over here. Many of you would ask, how do you do wet trap therapy for the neck area? Very simple. I just ask the parents to take a dupatta, cut it through, like just take a long strip of cloth, wet half the cloth, leave the rest of the cloth dry, and just wrap it around the neck of the child and leave it for about half an hour to 1 hour's time. The topical steroids were applied on this child, but that was done after the wet wrap therapy was removed. So wet wrap therapy was done only with emollients, twice daily, 1 hour each, for about 7 days. And these are the results within 7 days time. So you can see erythema has gone, scaling has reduced, quality of the skin is better, hydration, moisturization of the skin definitely has improved, and the quality of life of the child has improved. The child was not able to go to school, and this is what has happened. So, within a week, you are seeing these results without the use of any oral corticosteroids in this patient. Coming to the second case, this was another child who was an atopic child with severe ectosis vulgaris, and the child was just about 4 years old, and he was given a combination of glycolic acid, urea and lactic acid cream to be applied on the skin by another dermatologist. No harm in that, absolutely no harm, but the child complained of burning sensation when that was applied, and the parents refrained from applying it because it was burning for the child. We did nothing. We didn't even use topical steroids or any of the humectants here. Straight away, emollient, short contact wet trap therapy that we did, and the results that you see is after again 1 week of therapy, and it has completely resolved. This child comes back till date saying thank you, because these results were given without a single drop of oral medicines, and only with counseling and just moisturizers and wet trap therapy gave us this result and improved the quality of life of the child again. Coming to the third case, now this was again another child who came with a flare of atopic dermatitis along with a bit of papillar urticaria as well. So now this child was not treated ever with anything. So they had no clue what they were dealing with. Of course, we counseled the parents about the existence of atopic dermatitis, what it is and how we can control it. Now this child, he spits out anything that is given oral. So giving an antihistaminic also to this child was a challenge. So forget giving oral steroids or oral medications to this child. He was just about 3 years old, very notorious. All we explained to them was to do the wet trap therapy. And just on the second day, the parents were like, doctor, he is very comfortable. He wants to wear that wet trap therapy thing for about 2 hours, 3 hours, and can we leave it off like that? So yes, you are allowed to leave it off, provided you are dealing with it in summers, not during the winter time, because winters it's going to be cold. So this child again was treated with emollients, short contact wet trap therapy, the way I explained, twice daily, 1 hour in the morning and 1 hour in the afternoon. Topical steroids for only the red papilla lesions. And this is what you see after about 10 days of treatment. Again, no antihistaminics, nothing was given orally. It controlled even the pruritus in this child, and the child did extremely, extremely well. Parents were super happy, and they continued doing it for a very long period of time. Topical steroids obviously were tapered and stopped, and for the hotspots, the child was switched over to topical calcineurin inhibitors. So to summarize, wet trap therapy is an extremely beneficial method. You could use multiple modifications for it. What I generally like to do is the short contact emollient based wet wrap therapy, for the simple reason it is the easiest to do without any side effects. The clothes that I generally ask the parents to make them wear is, every parent is going to have one set of clothing which is going to be one size smaller than the child. So you can tell them to reuse those smaller sized clothes because they will be body hugging. Make sure it is cotton clothing because synthetic won't work. So definitely you can use the smaller size clothing. If you don't get, you can use cotton kurta, cotton pajama. Ask the parents or the mother to cut off an old sari in strips, and you can use those strips as bandages to wrap off each of the areas. It is an extremely cost effective method because you are not going to land up spending any extra money to do this therapy, and it definitely obviates the need for oral immunosuppressants in multitude of cases. So I would definitely give a 2 thumbs up for this method, so that it is beneficial for the child, it is beneficial for the parents, and it is good for you as well, because not many people are doing it. So if you start doing it, they will be very happy and they might just refer you more patients as well. So thank you so much. These were my 2 cents on wet wrap therapy. And I hope more and more people start utilizing it because it's a fantastic modality of treatment. Thank you so much.
So thank you so much. Yeah. Sameepa.
Thanks, ma'am.
Yeah, that was wonderful, and I had expected it to be wonderful, so I was right. And you've shown a very cost effective method, that's all we need, for developing countries and resource poor, places. If I'd written a paper on, atopic dermatitis
True.
and resource poor centers, and
True.
this is really a value addition to that. Thank you. I just have one question for you, Sameepa, because we are
Yes, ma'am.
quite late and we have one more presentation.
Yes, ma'am.
And that is, you've said that it obviates, the need for a systemic therapy.
Mm-hmm.
And it is also used for quite some time. What about, the role of vaccinations, in these children?
Ma'am, vaccinations, if the atopic flare is not there, can go on as a normal schedule as the pediatrician has prescribed. If there is an atopic flare, I would generally wait for about 3 to 6 weeks for the flare to subside and delay the vaccination for that much time. If we are
Right.
going to talk about below 5 years and initiation of immunosuppressants, our pediatricians are not at all happy starting immunosuppressants orally for children who have not been completely immunized. So I find wet wrap therapy to be extremely helpful in this group, in this subset, where I know that I cannot probably start an oral immunosuppressant, although I am very tempted to, because cyclosporin happens to be one of my favorite drugs for using in atopic dermatitis.
Yeah, even I'm not very fond of using immunosuppressives.
Yes.
Most of the time we manage actually without
Yes.
immunosuppressives
Yes.
in my practice.
Ma'am,
So
actually,
thank you
wet
so
wrap
much.
therapy, I think only thing is when you are explaining for the first time, you need to
Right.
invest time. That's it. That is your one-time investment. After that, you are good to go.
Yeah, probably this is where dermatologic nursing would help,
Yes,
So that is
definitely.
Thank you so much, Sameepa.
Thank you, ma'am. Thanks a lot.
And I'm going to turn over to Dr. Saple, sir. Sir, we have the last presentation of the day.
Thank you. I think before start with last presentation, Sameepa, it is quite fascinating to me.
Thank you,
Really
sir.
fascinated by this.
Thank you, sir.
And it's really useful. I'm going to start in my clinic. Thank you for
Thank you,
that.
sir. Thank you so
But I
much, sir.
want to ask in the light vein that you said it is useful for the patient, useful for the patient, useful for the, but what about the doctor?
Sir, it is the satisfaction in 7 days. The child who came to you scratching with a long face, he is coming back smiling, saying, Doc, I can go back to school. I think that's it. You don't need anything more than that for the doctor.
Yeah, I entirely agree. It is the way you get a satisfaction. It's beyond any comparison. I entirely agree. Thank you very much.
Thanks a lot, sir.
The next panelist, our next panelist is Dr. Dhanraj Chauhan, not Dhananjay Chauhan. His father is Dhananjay Chauhan. Yeah, I know him very well because he used to come for the HIV training to my clinic. So I know his father. He was interested initially in HIV. Anyway, Dhanraj, your topic is autologous fat transfer, we are going to ask questions on that. Again, I'm coming back to the HIV because that is the way we are living. Even today, my main practice is HIV. I get 25 to 30 patients of HIV every day for last 30 years. So, and one of the stigma of HIV is lipoatrophy. Their chicks goes
Yes, sir.
down, that becomes a stigma. And many people, they go under what is called is a psychosocial impact on that. So the fat transfer is one of the very important things. But here, I think we are expecting more common condition is acne scar. So can you go ahead?
Yes, sir, sure. Thanks a lot, thanks a lot, sir, for the opportunity to be here, and Rashmi ma'am, of course. And I'm so thankful to Rashmi ma'am for the same. Uh, Today, I'm just going to speak about how we can use fat transfer in acne scars, both microfat and nanofat. I've just made I've made a small video which I'm first going to play, and then we'll be taking on questions. So, Shailendra, can you please play the video?
Greetings. Today I'm going to present autologous microfat and nanofat grafting for acne scars. The steps involve harvesting the fat, processing it outside, and then injecting back inside below the scars. These are the results that we can expect with monotherapy with a fat transfer with no other treatments done. The initial steps involve cleaning the area, sterilizing it, and then creating the entry point for the cannulas to go in. The entry point is anesthetized with 2% dialocane, and then with a 18 gauge or a 16 gauge needle, the entry port is created. The cannulas first go straight vertically inside, and once the skin is passed with a giveaway sensation, we pass the cannula horizontally. Klein's tumescent solution is used, and the endpoint for tumescing is a very hard tumesced skin. Then the various harvesting cannulas are used with multi-ports or 2 or 3 ports. Different types are there which can be used. About 2 millimeter or 2.5 millimeter diameter cannulas can be used. Minimum negative suction pressure about 2 to 5 ml ideally in a 10 ml syringe, or maybe 5 to 10 ml in a 60 ml syringe can be used. The least amount of pressure that we use, maximum, is the graft survival. The left hand acts as a sensor and helps us in guiding where the cannula is going to and feeding the fat into the cannula ports. Once we have the fat outside, we then can process it in 3 different ways: washing and filtration, decantation, or centrifugation. In the washing and filtration step, what we do is we use normal saline to wash the fat of the tumescent anesthesia solution and also the RBCs and WBCs. Once we wash it, the washing fluid is then pushed out of the system. Various sizes of filters are used in order to prevent the adipocytes from going out and the stromal vascular fraction from going out of the system. This is a commercially available kit which can be used. In decantation method, no kits are required. We simply make the syringes stand for maybe 10 to 15 minutes, and then the fluid which collects down due to gravity is then pushed off the system. This is a very crude method but still can be done. In centrifugation, we use a centrifuge to separate the layers of fat, and then we see here the fat separated into the oil layer, the fat layer, and the fluid. Nanofat is created by emulsifying the microfat. So the fat is passed between 2 syringes connected by a 3-way connector about 30 to 60 times. And once we have the fat emulsification, we separate the fibrous tissue that is there in that, so that then the fat becomes a liquid which can then easily be injected through an insulin syringe or any syringe attached to a 27 or a 30 gauge needle. The fat grafting procedure starts by creating the entry ports, a port point from which all points in the acne scars can be reached. Again, a 18 gauge needle, and then the injection cannulas are smaller. They are about 0.8 or 1 millimeter in diameter, so that's about 20 gauge or 22 gauge. And then the fat is placed beneath the scars. We can do subcision before the procedure or during the procedure, or even the blunt cannula can be used to subcise part of the scars. The fat is placed in microboluses. The left hand again acts as a sensor, the eye for the procedure, and we place the fat beneath the scars about 0.1 ml to 0.2 ml per point, so that there's maximum survival of graft. placing large boluses doesn't help, because then the survival of the grafts reduces significantly, because then they don't give the required nutrition for the C. Nanofat can be placed intradermally, should be placed intradermally, like we place PRP, and there are also reports which support the mixing of nanofat and PRP as they act synergistically. Insulin syringe, the nanofat goes in quite easily and comfortably. The patient can just be prepped with topical anesthesia before the procedure, and then just like we inject PRP, we inject the nanofat. So this whole procedure takes about half an hour to 45 minutes to complete, and is quite painless for the patient, giving very satisfactory end results. As it is a minimally invasive procedure, maintaining sterility is very important, but it can definitely be done in our dermatology clinics. These are the few results of patients done with monotherapy fat transfer, or in a few of them, one or two treatments have been combined. As we can see, it's quite satisfying. Do try. Thank you for watching.
Thank you, Nandraj. It was,
Thank you, sir.
I think these results are very good. Have you seen any complications?
Uh, Not really. So some bruising is also definitely there. If you are in the glabular region, the risk of
Any secondary
the risk is
infection?
higher. Not at all. So at least the few cases that I have done, the limited number of cases I have done, no. If proper aseptic precautions are used, even in our OPDs in our procedure room, if we do the procedure with proper aseptic precautions,
Okay.
the risk is very low because it's a minimally invasive procedure.
Okay, so with all precautions, yeah, this is very useful because scar can be treated without much, and the results are quite encouraging. I think we have come to the end, and let us wish Rashmi Sarkar best of luck for her election.
Thank you so much, sir. Thank you.
Yeah.
It has been such a pleasure.
Yeah, and we'll hand
Thank
over.
you so much, ma'am, and best of luck for the elections too for me.
Thank you. Thank you. It has been such a pleasure and honor, to have been there with sir and with all of you, because the work that you've been doing, you have your heart in the right place. That's most important. That all these innovations are for the patient, so you have your heart in the right place. Thank you so much.
Thank you, ma'am.
All the very best, Rashmi ma'am.
Thank you, Kanika. Thank you so much.
Good luck, ma'am.
Thank you.
Yeah, I think there is a good luck from everybody, correct?
Right,
So I think, Rashmi, can we hand over to Shailendra before
Yes.
handing
He has
over?
done such good work getting so many people together, and
yeah, we must thank FDC, Zocon, and Shailendra and his team for organizing such a nice program.
Yeah, FDC did a wonderful
Thank you
job.
very much, sir.
Shailendra, yeah.
Thank you, ma'am. Thank you. Thanks a lot, ma'am. Now, to give the vote of thanks, I would like to thank Professor Dr. D.G. Saple and Professor Dr. Rashmi Sarkar for excellent moderation of the session. They have extracted all practical pearls with their wonderful moderation skills and taken it to the next level. I would like to thank all the panelists, starting from senior most and stalwart Professor Ajit Kundu. He was wonderfully covered TSDF, and thanks for coining the term, sir. Professor PVS Prasad for his excellent presentation and crisp slide to cover the topic of pure neural leprosy. Professor Dr. Taru Garg covering RVVC and explaining the role of fluconazole in the treatment. Professor Dr. Viju Vasudevan for acute methotrexate toxicity. Thank you, sir. Dr. Jha for highlighting the role of counseling in the management of dermatophytosis. I'd like to also thank Dr. Kanika, Dr. Udaypreet, Dr. Samipa, and Dr. Dhanraj for wonderfully covering the topic and giving pearls to all the audience dermatologists. I would like to thank all the audience for taking out time on holiday and join the session. Thank you very much. And finally, a big thank to technical team and Mr. Prashant for smooth execution of this webinar without any technical glitch. And last, ma'am, I wish you all the very best for your presidential election and candidature, ma'am.
Thank you so much, Shailendra. And thanks for everybody being here. It's a long time. And the audience also got good feedback. They've been there because we've been standing between them and the Sunday dinner. But I think we've given you lots of food for thought. Thanks to you, sir. We could do this together. And I'd like to also wish Dr. Abhishek Kumar Jha, all the best for his joint secretary's post, because I've really seen him working. He's been like a younger colleague, a younger brother almost, because I've just seen him grow, in front of my eyes.
Thank you so much, ma'am. Thank you.
Abhishek, best of luck.
Thank you, sir. Thank you, sir.
All the
Best of luck, sir.
Good luck, sir. Good luck.
Chayo.
I think,
Chalo.
okay.
Prashant,
Okay.
close the session.
Good night, everyone. Bye-bye.
Good night.
Thank you.
Yeah.
Take
night,
Bye.
ma'am.
See
Yeah,
you.
good
Take
night so
care.
much. I
Bye.
see you.
Yeah.
Bye.